Good day, everyone, and welcome to the second Grand CPC for the school year 2020-2021 of the Janelta Foundation School of Medicine, University of Perpetual Help Delta System for the third year medical students. I'm Dr. Iftiza Haron, and with me is Dr. Jennifer Mateo as your host for today's event. And to start off, may we listen to the Philippine and Indian national anthems to be followed by the university's mission vision.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang mag-ibig, helas ng sinakanan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa manlulupin, di ka pasisingil, sa nagagang tutok sa simoy at sa langit mong pagaw, ay hinatang tulad, awit sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nag-iindig, ang bituin at araw niya kailan ang may di magtitindig. Lumalang araw ng walhagit pagsinta, buhay langit sa piling mo. Ang inigaya ng pagkay mga api, ang mamatay ng dahil sa'yo.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Heavenly Father, we come to you this hour asking for your blessings and help as we gather together. We pray for guidance in the matters at hand and ask that you would clearly show us how to conduct our work with a spirit of joy and enthusiasm. Give us the desire to find ways to excel in our work. Help us to work together and encourage each other to excel. We ask that we would be challenged each other to reach higher and farther to be the best we can. We ask this in the name of the Lord Jesus Christ. Amen.
Janelta Foundation School of Medicine Vision. The Janelta Foundation School of Medicine, believing that Christian character building through quality education is nation building, aspires to be an outstanding center of excellence in medical education, training, research, and community service, committed to the achievement of the highest quality of life. Janelta Foundation School of Medicine Mission. The Janelta Foundation School of Medicine is dedicated to developing a professionally competent and holistic healer, socially responsive to the needs of humanity and imbued with moral, ethical, and spiritual values. Goals: to develop the complete physician instilled with values geared towards health promotion and disaster preparedness, to enhance faculty development through sustained and relevant learning programs cascaded to the studentry, to contribute to the upliftment of the community through the relevant and viable health services, to promote research in the appropriate medical services with significant impact to society.
continue with our activity, let us listen to the special messages to be given by the President of University of Perpetual Health Delta, Mr. Anthony Jose M. Tamayo, and the School Director, Dr. Arnoldo S. de Guzman.
A very pleasant day, my fellow Perpetualites. I hope that you are all safe and healthy as we start the school year 2020-2021. This school year, as we all know, will be different and more challenging as we adapt to the new normal in the education landscape brought about by the COVID-19 pandemic. True to our commitment, we never allow the pandemic to hinder our mission to produce Perpetualites who are helpers of God and who will contribute to nation building. Hence, the university strives to continue to provide quality instruction through innovative ways to seamlessly shift from a purely traditional or face-to-face learning to flexible learning options, online or distance learning in all levels, while, of course, paramountly ensuring the safety and security of our students, faculty, and non-teaching personnel. The pandemic has also presented us with an opportunity to have more innovative improvements to our online learning approaches to better engage our students. We shall remain using the LMS or Learning Management System with features that are well suited for long-term online learning. Furthermore, laboratory classes will now have access to Labster, which is an innovative laboratory solution software. We have also upgraded our bandwidth with better internet connectivity. Now, challenges are expected to emerge at the onset of the implementation of online learning, but we hope that these will encourage our students to become more responsible and self-directed Perpetualites. Take this opportunity to grow and be more productive while spending the rest of the school year at home. Continue to value your education and learn as best as you could. I would like to take this opportunity to perpetually thank you all, parents and guardians, for entrusting to us your child's education. You are essential partners of our university in the learning and formation of our children. Parental supervision and guidance are even now more crucial in helping learners succeed in transitioning to distance learning or home-based learning. Meanwhile, our faculty members have been trained for months and have prepared learning modules in order to deliver the quality education our students deserve. We further hope to inspire our faculty to explore more engaging and innovative ways to deliver the lessons through more authentic learning activities. As best as you can, teach and train the next generation of Filipinos to become better equipped and skilled nation builders. To our teaching and non-teaching personnel, thank you for your resilience and adaptability during these very trying times. We are all coping with the adverse effects of this pandemic, and I know that we are all learning from this experience. Finally, I hope to see you all again in campus when the pandemic is over. Let us continue praying to our Mother of Perpetual Help and the Lord Jesus Christ to protect us and guide us and watch over us during the rest of the school year. I also fervently pray for you and your family to perpetually stay safe and healthy. May God bless us all.
A blessed morning to all. I am very happy to be with you today, and I know that we are all excited to see each other in person if the situation permits. Allow me to congratulate everyone participating in this 6th Grand Clinical Pathology Conference with much positivity, new mindset, new paradigms, and renewed hope. Amidst the new and major changes in the educational landscape that we are facing, we have to remain focused on the realities that the new normal has brought about. One of these is the importance of our topic today on pathology. As the saying goes, without pathology, there is no medicine. Without laboratories, men of science are soldiers without arms. More than ever, during this new normal, pathologists and medical laboratory scientists' job is, in many ways, just beginning. Their essential role in testing for COVID 19 over the past year and in the months and years going forward cannot be underscored enough. As future perpetualite physicians, let us not forget the four pillars of the perpetualite education, namely Christian in living, Catholic in doctrine, Filipino in character, and perpetualite in virtue. Indeed, the pandemic has made us realize that what matters in life are the essentials. These essentials are more immaterial than material, more infinite than finite, and more spiritual than physical. The perpetualite mottos of character building is nation building and helpers of God speak well of these essentials. The perpetualite physician is therefore a servant healer formed after the image of the great healer, Jesus himself. Yes, we have prepared ourselves, and the university continues to equip us to face and experience the new normal. I commend the organizers of this conference. Indeed, this is a proof that learning in the new normal is possible and commendable. Allow me then to thank you all for your continued faith, trust, and support to the perpetualite education. My dear friends, you embody the perpetualite education. You are the frontliners of the perpetualite education. Before I close, allow me to invite everyone to thank God for the gift of good health. We ask Him to bless every member of our families and to also bless our perpetualite family. May we together hurdle this year with flying colors and emerge victorious amidst the uncertainties and challenges of this pandemic. May our Mother of Perpetual Help, our patroness, be our guide and inspiration. Thank you, and together we say, we love Perpetual.
We would like to thank our University President, Mr. Tamayo, and the School Director for the very profound and inspiring messages. Once again, thank you, sirs. To properly welcome you to this event, we would like to hear a welcome remarks and to give us a short background of this Department of Pathology annual activity from the Deputy Chair of the Department, Dr. David Brian Oved.
Good morning. A French mathematician once said that science is facts. Just as houses are made of stones, so is science made of facts. Yet, a pile of stones does not make a house, and a collection of facts is not necessarily science. In the same way, medicine is made of scientific facts about human diseases. Yet, wielding a vast collection of medical knowledge does not necessarily make you a good doctor. This CPC reminds us that before we became efficient health managers, we were once health detectives. I believe this detective role is what separates a doctor from mere technicians. A physician has to ask and derive the right questions from an ocean of medical facts and to seek out the answers for those questions, even if those answers do not represent the absolute truth. Sometimes, a physician has to step back and embrace doubt to better serve his or her patients in the future. The day that a doctor stops questioning and analyzing about what is really going on with the patients is the day the doctor fails the patients. Your time for didactics ends here. Next school year, your true study of human suffering begins. Good luck.
Thank you, Dr. Alveda, for giving us insight on what this activity is all about. This Grand CPC will not be possible without the help of the entire faculty members of the department. And with that, I would like to introduce each faculty member. We now proceed to the introduction of our panel of judges. Our first judge is a graduate of BS General from the University of Santo Tomas in year 1977. She also obtained her medical degree from the same university in year 1981. Following her graduation, she had her postgraduate internship in 1982 at Rizal Medical Center. Then she had her residency in anatomic and clinical pathology at Rizal Medical Center from years 1983 to 1987. After residency training, she took the certifying board examination both in anatomic and clinical pathology in year 1988, where she topped both disciplines. During the early years of her professional career as a pathologist, she worked as an instructor in clinical and anatomic pathology at Pamantasan ng Luzon ng Maynila from years 1988 to 1990. Since then, she had been a visiting consultant at Mandaluyong City Medical Center, UP Health Service, head of the laboratory of various private clinical labs. She is also the owner and head of the Laboratory AC Alvarado Clinical and Diagnostic Center. Further, she is also the chairperson of the Department of Pathology at East Avenue Medical Center, also an OIC officer as a chairperson at Quirino Medical Center. She is affiliated at different organizations and had several publications of research papers. I'm honored to introduce my former chair, Dr. Ana Rose Cariaga Alvarado. Our second judge is a police lieutenant colonel, a pathologist, a medical legal officer, and a DNA analyst. For his education, he finished his medical degree at Remedios Trinidad Romualdez Medical Foundation, Tacloban City. He completed his residency training both in anatomic and clinical pathology at Veterans Memorial Medical Center, Quezon City. Further, he is also a nurse by profession and obtained from the same school. He is a member of the Philippine Medical Association, Tacloban Chapter, a member of the Philippines Nurses Association, Tacloban Chapter. He had several publications and affiliations. Let us all welcome Dr. Jericho A. Cordero.
Our third judge is a fellow of the Philippine Obstetrical and Gynecological Society. For her education, she took a Bachelor of Science in Medical Technology at the Far Eastern University, Dr. Nicanor Reyes Medical Foundation. She also obtained her medical degree from the same university in 2000. She pursued obstetrical profession starting at residency training from 2002 to 2006 at the Capital Medical Center. She then took and passed the certifying board exams in 2007 and 2011 for POG's Diplomate Part 1 and Part 2 respectively. She became a fellow of the Philippines Obstetrical and Gynecological Society in 2013. She had been a chairman of the Department of Obstetrics and Gynecology at Bernardo General Hospital in Quezon City from 2013 to 2015 and 2017 to 2019. Further, she is a member of the following organizations. She has also received several awards and recognitions and published several research papers. Let us all welcome Dr. Natalie A. Tumao. We are happy and honored to have this distinct and exemplary and well-loved colleague. Firstly, she is a magna cum laude from the Far Eastern University, Manila, and with a bachelor's degree. She then continued her education in the same university where she finished her Doctor of Medicine. She then took her specialty residency training in anatomic and clinical pathology from 1978 to 1982 at the Philippine Heart Center for Asia, Quezon City. Subsequently, she took and passed specialty board exams for the clinical pathology in 1983 and for anatomic pathology in 1986. She then became a fellow for the said specialty in 1989. She also holds a master's in public health science 2002 from University of the Philippines, Manila. At present, she is a pathologist of several hospitals and a professor at the NCU College of Medicine. She also holds the following positions. In 2017, she is a recipient of the Distinguished Service Award given by the Philippine Society of Pathologists. She is also affiliated at the different societies. Our judge has published several papers where she co-authored. Further, she is commissioned major with different commendations from Armed Forces of the Philippines Medical Center. Everyone, let us welcome Dr. Leonisa Santos Tagon.
Before we move on further, I would like to present the criteria for judging. 1. Graphics and video content and layout, 20 points. 2. Presentation skills, 20 points. 3. Mastery of the case and flow of the case discussion, 20 points. 4th, ability to answer the judge's questions, 20 points. Last, MCQ questions, 20 points, with a total of 100 points.
We proceed to the first part of the competition, which is the video presentation, and followed by the Q&A portion with the assigned judges. The following are the guidelines. First, each house will have 5 presenters. These presenters are pre-selected by the houses among its members. Note that only the 5 presenters are allowed to participate in the Q&A activity. The rest of the members of each house and the respective mentors are kept out from the activity. Each judge is assigned with one house to question and can direct questions to a specific presenter or to any members of the group. Each presenter should be prepared to answer since the grade of one presenter will be the same for all members of the group. Each group or house is given a maximum of 10 minutes for the question and answer activity. Note that each minute excess from the given time, 1 point will be deducted from the group. A 2 to 3 minutes roundtable discussion with the respective judges following each presentations. The order of presentations of the houses is randomly pre-drawn and as follows. The House of Slytherin will be judged by Dr. Natalie Tumang. This house is mentored by Drs. Rogelio Acosta and Maritis Umbao, and guest mentor, Dr. Audrey Angeli from the Department of Preventive Medicine and Community Health.
Gather our
price of your greed is your son and your daughter. What you gonna do when there's blood in the water? Look me in my eyes, tell me everything's not fine. All the people ain't happy, and the river has run dry. You thought you could go free, but that system is done for. If you listen real closely, there's a knock at your front door. You'll never get free, lamb to the slaughter. What you gonna do when there's blood in the water? The price of your greed is your son and your daughter. What you gonna do when there's blood in the water?
Now it's time to begin with the case.
Our patient AG is a 27-year-old female from Africa. She's 38 weeks pregnant, G4P5.
History of present illness. Chief complaint was vaginal bleeding. 12 hours prior to admission. There was abdominal pain radiating to the back, accompanied with abdominal cramps and uterine contractions. 1 hour prior to admission. Vaginal bleeding with painful bilateral lower limb weakness, associated with muscle cramps, sudden twitching and jerking movements were noted. She had not undergone prior surgical procedures, but was hospitalized due to persistent anemia. On examination, tachycardia, fetal tone of 180 beats per minute, and massive vaginal bleeding was noted. Potassium, which was 3.0. CPC revealed that her hemoglobin was 7.0 grams per deciliter, and hematocrit was 23%. Initially typed A positive, but later changed to type O. In the first 24 hours, 10 units of type O blood was transfused, of which 5 units were consumed, with hemoglobin of 10 grams per deciliter. On day 2 of admission, the remaining 5 units were then transfused. However, hemoglobin levels remained low despite multiple transfusions. On the 3rd day of hospital admission, abdominal cramps and uterine contractions were noted, resulting in the delivery of the baby, who expired after 2 minutes.
In the obstetric stream, our patient had urinary at 12 years of age with a regular cycle lasting 6 to 7 days accompanied by dysmenorrhea and observed to be heavy, profuse with no use of sanitary napkins. She is G4P5503, all delivered including twins via NSD by 2 weeks. Both the older twins died after birth.
Past medical history. She was regularly hospitalized with anemia since childhood and received regular blood transfusions.
Regarding our patient's socioeconomic history, she came from a poor family that lived as nomads with a caterer. She was second in a group of 5 children. 2 of her siblings were twins who died at an early age. She was initiated at 14 years into the S Society. She had undergone female mutilation rites. After her father's death, she was adopted by her uncle, who eventually made her one of his brides as part of their tribal customary tradition.
Personal history. As per claim, she does not smoke nor consumes alcohol.
She had a positive family history of cardiovascular diseases, diabetes mellitus, anemia, malaria. Her father had multiple myeloma, and both her parents had thalassemia.
Review of systems. It was seen that she had dizziness, muscle cramps of the lower extremities, involuntary jerking movements of the lower extremities as well. But she did not have numbness, blurring of vision, or headache.
Her physical examination revealed her to be conscious, alert, and tachycardic. Her vital signs showed blood pressure of 90 by 60 mm mercury, pulse rate of 102 beats per minute, respiratory rate of 24 cycles per minute, and temperature of 37.1 degrees Celsius. Hint examination showed no fundoscopic abnormality, no carotid bleed, no jugular vein distension. She had clear breath sound bilaterally, heart rate was 102 beats per minute, regular rhythm, normal S1 and S2, no murmurs, gallops, or trills. Her abdomen was soft, globular, and moderately tender upon palpation. External genitalia revealed hairy mouth pubis and no remarkable lesion, both on the labia majora and minora. She had undergone clitorectomy, her bladder was unappreciated, and there was 50 to 100 ml heavy profuse bleeding with radiated vaginal wall. Her cervix was soft and slightly open. The patient refused a rectal examination. Her neurological examination showed her cranial nerves were within normal limits, bilateral upper extremity showed motor strength of 5 by 5, she had index sensation to pinprick and soft match, DTRs were symmetric with a score of +2, bilateral lower extremity had equinovarus posture of the ankles, hyporeflexia, and sustained left ankle tonus. DTRs were symmetric with a score of +2. Lower limb strength assessment was limited to pain and spasticity and frequent urinary pattern and jerks.
These are the lab diagnostics provided: the RBC, hemoglobin, HCT, MCV, MCH, MCHC, platelet count, albumin are low. The RDW, eosinophil count, APTT, PT, magnesium, phosphorus, LDH, and globulin are high. Peripheral blood smear reveals microcytic hypertrophic red blood cells with an isopoikilocytosis. This is the ECG and this is the X-ray provided. Salient features. The patient is female, Bravida 4, parity 5, with one living child. She had a poor obstetric history, with origins from Africa and post-citric economic status. She delivered the 5.5 kilogram baby, accompanied with crampy abdominal pain radiating to the back, and profuse vaginal bleeding with persistent anemia. Mild hyponatremia and mild hypoglycemia were noted. Family history comprised of thalassemia and multiple myeloma. She had multiple blood transfusions since childhood. On performing blood tests, reduced platelet count and prolonged perfusion time and activated partial thromboplastin time were noted.
Course in the world. On the third day of admission from the integrated the patient developed persistent severe surgery and approximately 14 units of type O positive type and cross which fresh whole blood was immediately transfused and consumed within 24 hours. The bleeding was persistent, a ruptured blood vessel was considered and contemplated for exploratory laparotomy. Hysterectomy was scheduled and carried out due to persistent profuse bleeding. Unfortunately, during the actual operative procedure, the patient suffered a cardiac arrest and died intraoperatively.
Initial impression is hypovolemic shock, secondary to uterine injury.
Do we have any other possibility related to the case?
As for the diagnosis, I have come up with uterine rupture. There are some symptoms that will rule it include excessive vaginal bleeding, abdominal tenderness, tachycardia, hypotension, and overdistended uterus.
I think you forgot something important in your differentials that will rule out the possibility of uterine rupture, as there was no bulge noted near the pubic bone. The fetus was delivered by a normal spontaneous delivery. The patient had elevated heart rate and there was no prior history of cesarean delivery.
For the last one, you have proven me wrong, but I have come up with another solution, that is uterine artery ruptures. There are symptoms that will rule it in, that includes profuse vaginal bleeding, hypotension, tachycardia, and abdominal distension.
So here you go again with your positive points, forgetting that uterine artery rupture is a rare incidence and our patient had no history of aneurysm or endometriosis.
Then what about the retained placenta? It has most of the symptoms that will help it to distinguish from the other causes. That include crampy abdominal pains, hypotension, and last one is profuse vaginal bleeding.
Well, it may be near accurate, but let's not forget that our patients had no signs of retained placenta after 24 hours. There was no signs of fever, and the patient had no foul-smelling discharge.
Let's now reveal the final diagnosis. Reveal your diagnosis!
The final diagnosis for this case is hypovolemic shock secondary to early postpartum hemorrhage secondary to uterine atony.
Now that we have the final diagnosis, let's understand the pathophysiology behind why this patient died. We suspect that the patient had preeclampsia. This suspicion arose as the patient had decreased blood platelet count, elevated LDH and ALT levels, which actually fulfilled the Class 3 Mississippi criteria of health syndrome, which is linked with preeclampsia. The suspected rise in blood pressure would have led to the rupture of the spiral vesical artery into the physalis, leading to hemorrhage. Further expansion of this hematoma would have caused further disruption of other blood vessels and the separation of the placenta from the uterine wall, thus leading to placental abruption. This would explain the antepartum bleeding the patient had witnessed an hour prior to admission. The placental abruption would have led to the release of tissue thromboplastin factor into the maternal circulation. This would have led to the consumption coagulopathy via the activation of the extrinsic coagulation cascade, thus leading to DIC. This could be observed in the patient by the lab reports of the increased or prolonged PT, APTT, and the decreased platelet count. However, these values were not significant enough to cause overt DIC but would have contributed to the postpartum hemorrhage. The patient's state of anemia would have led to the dysfunction of the uterus due to the decreased hemoglobin and oxygen supply to the myometrium. This would affect the contractility or impair the contractility of the uterus postpartum. As the mother had delivered the 5.5 kg fetus, a macrosomic baby, vaginally, this would have caused the over-distended uterus to fail to contract postpartum, thus leading to profuse bleeding. In response to the profuse bleeding, she was transfused 14 units of blood. This massive transfusion would have further diluted the clotting factors already present in the maternal blood, which would have contributed to further bleeding. In response to this, an operation was performed to find out the cause of bleeding. However, due to the severe volume depletion, this would have led to hypovolemic shock, and eventually that led to the cardiac arrest and death of the patient. The main cause of death is hypovolemic shock. The antecedent cause of death in this case is early postpartum hemorrhage. The underlying cause of death is uterine agony. The other significant factors affecting the death of this patient include DIC, placental abruption, macrosomia, anemia secondary to thalassemia, and massive blood transfusion.
This is it, guys. This is war. What are we waiting for? We'll do whatever it takes, for we are snakes. We are in it for the win. We are Slytherin.
I am Dr. Dina Miranda, and welcome to the Q&A portion of the second Grand CPC for medical students of the Junelta Foundation School of Medicine, school year 2020-2021.
So good afternoon. Welcome to the Q&A portion for this online CPC. And with us is our second judge, Dr. Natalie Tumangmam.
Yes, Doctor.
Afternoon.
Good afternoon. My question is regarding the general data. Any comment with the gravidity and parity? It said G4V55001. Can you comment on this?
Thank you, Podak, for the question. We suspected that there must have been an error in the as in the total terms, the total fetuses that were carried into pregnancy were 4. We believe that the last one, the 5001, there would be a change in the number of living children.
So I think it should be gravida 5 para 4.
Yes, Podak.
You do not have to count the twins as 2 pregnancy. So can you get it?
Opo, Doc.
Okay. And then as for the history of present illness, patient had a history of persistent anemia before. Given the case, what could you have asked for if you were in that scenario? Regarding the previous hospitalization due to persistent anemia.
Well, we would have checked upon the other lab studies as well, and just tried to figure out the severity of thalassemia in the patient. We were given just the family history, as in the mother and father were thalassemic, and then the family history of multiple myeloma was present as well. We would try to enforce the severity and to make sure, because she did receive consecutive blood transfusions, but with the risk of iron overload or the iron overload toxicity being a high risk factor, we would try to assess that. And there was also the cases in which in thalassemia patients, the fibrinogen levels tend to be less and the platelet counts tend to be less. We would also try to keep a check on that and decide if necessary factors or platelets should have been provided for.
Okay. And as you can see for the physical examinations, there's no mention of the fundic height and the fetal heart tolerance there, but the fundic height is not mentioned because no mention also of the previous weight of the baby. So we cannot tell if this pregnancy is so large compared to previous pregnancy. And as for the clinical course, there's a discrepancy because in the history of present illness, it said that bleeding was controlled subsequently. And then on the clinical course, it said after delivery, there's excessive blood loss. Can you see that? Because that
Yes,
history is a little okay. And then given the situation, postpartum vaginal bleeding, aside from transfusion, what could you have done or what could you have checked to assess the patient?
Ma'am, first we would have always checked for her ABCs. Then, ma'am, we should also, because of the postpartum hemorrhage, we should make sure like how much blood the patient has already lost, because she had antepartum bleeding. When she came in, she came in because of vaginal bleeding. So we should also see how much blood she has already lost.
And for Doc, to add to that, we would have checked. There was no mention about examination of the vulva or the cervix at the time of delivery. We checked for lacerations, since sometimes these could like 5.5, a macrosomic baby coming out vaginally could prove to be a big risk factor for lacerations. We would also tend to check by palpation of the abdomen to see if the uterus is firmly contracted. Along with that, should we have to do any maneuver, we would try to manually massage the abdomen and then provide oxytocin intramuscularly.
Okay. What is the what could be the cause of the atony in case, because you are entertaining atony?
Ma'am, because of the macrosomic fetus, the fetus was 5.5 kgs. So because of the over-distended abdomen, we thought of atony.
Okay. How about for the chest X-ray? Any reading for that?
Ma'am, for chest X-ray, we didn't really see the appreciable change except for mild edema. So we did not really put that as our main focus.
Okay. And then how about for the transfusion? Do you think it's too massive to do it in just 24 hours?
Yes, Paul, it is somehow quite massive. But as a patient, patient's hemorrhage is continuing postpartum. She really needed that transfusion so that the baby inside her would eventually be alive. But sadly, it didn't. Also, there's a huge risk of having iron overload, which I think that has been overlooked because it has not been told that there has been chelation done at that moment of transfusion. So chelation has should be done at that time. So I think that is one of the factors that they overlooked, doctor. Thank you.
Okay, and ideally, what do you give after several transfusion?
Platelets, fresh frozen plasma, clotting factors.
Aside from that, like for example, after you have transfused 4 units, ideally you should give calcium. Do you know the reason why?
There tends to be hypocalcemia.
Why? How does it cause hypocalcemia?
When there's additional blood being supplied into the patient, there tends to be an additional potassium, and due to the ion changes, the calcium tends to go inside the cell.
And then aside from that, because the preservatives in the blood, there is a citrate, it can bind to the endogenous calcium, so leading to hypocalcemia. And then what happens if there's hypocalcemia? What can happen? Okay, arrhythmia can happen. Okay, so we should be watchful if you're going to transfuse massively. And then as for the discussion, you did not you rule out retained placenta, right?
Yes,
and yes, you mentioned that post because it usually happen after 24 hours. Okay, and how about, and also the absence of fever and the foul smelling discharge. So I would like to tell you that sometimes retained placenta can also cause early hemorrhage. So we have to evacuate all the blood clots or retained placenta because by experience, we have noticed that. And also, we have to check the bladder because we do not know the bladder can be distended so that it's preventing the contraction of the uterus. And why should the uterus be contracted after delivery? What's the pathophysiology of the contraction?
Ma'am, actually, there's ma'am, if the uterus is not contracted, the blood vessels are not contracted, so they'll keep on bleeding.
Okay.
So that's why we give oxytocin to constrict the blood vessel to stop the bleeding.
Okay. And how do you give the oxytocin?
Ma'am, we give infusion 10 units per.
10 units. Can you cite a side effect? What to watch out for if you give oxytocin?
Ma'am, if we give oxytocin during labor, it can also cause uterine atony. So we should always give it after delivery.
All right. So our time is up already. You have already consumed the 10 minutes allotted time for Q&A for this house. So thank you so much, doctors.
Thank you.
Thank you po.
The students can now leave the platform.
Dr. Tumang, thank you for gracing our CPC as one of our judges, renowned judges.
Thank you.
And I hope you enjoyed watching their audio visuals, and maybe you will be able to pick up something. Just want to get your feedback, recommendations on this way we put up this CPC that we have for the students in a very short message.
So actually, doctor, this is the first time I became a judge, and this is the first time also I encountered such a case, because during our time, the CPC, we have the pathologic report, and I even asked Dr. Miranda because the history seems not written properly. there are errors, but I think it's also a way to motivate the student to check if all the informations are correct or it's just an typographical error, and also a very difficult case because if it's really a different situation from the hospital setup if given this case. And also actually may mga questions pa ako sana about thalassemia, pero I think they have discussed that in their clinic discussion, and masyadong high-tech sila. So it was an enjoyable experience to be a part of this CPC.
Doctora, this case is an actual case I had in Africa. Anong feeling mo? It's the same. Talagang very mababa talaga. So you have to compensate kapag ganyan. You're coming from sa atin kasi we have a different way and they also have a different way. So pag ganyan pag international na kasi ang natin, ang mga cases, tapos you're in that type of situation, you have to compensate for kung anong kulang nila. So this is a training for them. Para if they were put in the same situation, what would they do? Kasi masyadong high-tech, you go to this country of limited resource, ayan na, bulag, blinded ka na. So, it's our training sa mga estudyante namin.
So, any more comments, Doc?
For this group, no more. And I will still watch the other group for the scoring. Thank you.
For the House of Gryffindor, this will be judged by Dr. Ana Rose Carriaga Alvarado. The House of Gryffindor is mentored by Drs. John Timogene Tuwasil and guest mentor from the Department of Obstetrics and Gynecology, Dr. Ina S. Irabon.
I know a house where dwell the brave at heart. Scarlet and gold, our chivalry sets us apart. In the wizarding world, no one comes close. Everybody knows that when evil is near, we will always be here. Once upon a time, from the House of Gryffindor, home of the brave, the second Grand Clinical Pathological Conference commences. A pregnant 27-year-old African woman came in with vaginal bleeding.
A patient's hemoglobin is low. Give her 5 units of A positive. No, stop! The patient is type O, not A. We ordered 10 units of type O blood. Ah, blimey. Despite transfusion, her hemoglobin is still low.
Once I was stable, Dumbledore asked for my history.
Patient AG. You are 38 weeks pregnant, correct? Okay, tell me what happened.
12 hours ago, I experienced abdominal pain radiating to my back. It was grumpy with a 10-minute interval. Then an hour before I came into the infirmary, both of my lower limbs were painful and weak. It was cramping, twitching, and jerking. I remember when I was young, I was hospitalized for persistent anemia and received regular blood transfusion. I also recall my menstruation having heavy and profuse bleeding. You see, I come from a poor family. 2 of my siblings died at an early age. When I was 14 years old, I married my uncle. My family has a history of heart disease and diabetes, as well as anemia and malaria. My father had myeloma and both of my parents had thalassemia.
Thank you for your time. I'll let you rest now. Ah, the physical exam of the patient. So she is tachycardic and tachypneic. Her abdomen was moderately tender and palpation. Her neuro exam of the lower extremities was limited due to pain and frequent myoclonic jerks. Ah, students.
Good morning, Professor.
Good morning, Professor.
Good morning, Professor.
Come in, come in. Perfect timing. Tell me what the CBC and coagulation study show. Yes, Miss Granger.
CBC shows severe anemia, increased RDW, thrombocytopenia, and a defective common clotting pathway.
Now who can tell me about the blood
Blood chemistry shows low sodium chloride in albumin and a high magnesium, phosphorus, AST, LDH, and globulin.
How about the peripheral blood smear?
PBS shows microcytic hypochromic blood cells with aneuploidylocytosis.
Amazing, Miss Granger. 10 points to Gryffindor.
On the 3rd day of my admission, I developed abdominal cramps with uterine contractions, prompting the delivery of my 5.5 kilograms male infant, but eventually he died after 2 minutes. 3 days following the delivery, I developed a persistent severe vaginal bleeding, despite blood transfusion, so hysterectomy was performed. Unfortunately, during the actual operation, I died intraoperatively. Can you solve the mystery of my death?
Students, this belongs to the patient. This X-ray shows pericardial effusion and cardiomyopathy, while this ECG shows left atrial enlargement and non-specific ST T-wave changes in inferolateral lids. Well, taking into consideration of the patient's history, how do you diagnose this patient?
Professor, the case is obstetrical in origin and we classified it under accidents of pregnancy. We are considering uterine rupture, placenta previa, and a rupture of placentae with possible underlying hematologic conditions, namely alpha thalassemia and von Willebrand's disease. Uterine rupture is spontaneous tearing of the uterus, which can occur late in pregnancy or in active labor. It is more common in African multiparous women, and physical exam findings of the patient are consistent with it too.
However, the patient didn't present with the following.
Placenta previa was also considered because of your multiparity and multifetal pregnancy, as well as the massive bleeding causing anemia and multiple blood transfusions, and not to mention your PE.
On the other hand, I had no history of tobacco and drug use, of cesarean sections, placenta previa, nor endometritis, as well as painless vaginal bleeding, and my abdomen was gentle on palpation.
Alpha thalassemia could be a hematologic cause of a rupture of placentae. It is an inherited blood disorder wherein a decrease in normal RBCs causes a decrease in hemoglobin, resulting in anemia. It is common among Africans and those with family history of diabetes and multiple myeloma. She also mentioned she had persistent anemia since childhood.
That's right. Her lab results do coincide with anemia and thrombocytopenia. Let's see. There's an increase in AST, LDH, globulin, and a decrease in albumin. Oh, and she has prolonged PT and PTT. The tachycardia and left atrial enlargement suggests a cardiovascular disease, and her neuro exam also concur with thalassemia.
Look, Ron, there are still some ruling out factors like her blood chemistry. Her family history of malaria is also conflicting because thalassemia has protective effects against it. Liver damage and hypersplenism still needs further study, and we need to check for RBC integrity to consider malaria.
Von Willebrand's disease is generally a commonly inherited bleeding disorder, and women are more affected due to the bleeding challenges of menstruation and childbirth. Her tachycardia and hypertension after a heavy vaginal and postpartum bleed are consistent with anemia and thrombocytopenia. The defective clotting factors and PBS are rule-in factors as well.
However, von Willebrand's disease doesn't usually present with neurological findings, and the patient's prolonged prothrombin time is conflicting.
Our last differential is abruptio placentae under the accidents in pregnancy category. From its 4 classifications, this patient is under class 2. This could have caused the massive bleeding due to the separation of placenta from the uterus, causing accumulated blood to exit. Her anemia could have contributed to it too, and fetal tachycardia was likely due to the placental detachment.
My tachycardia and hypotension may be due to the large volume loss, and my tender abdomen was also a ruling-in factor. My labor contractions, mysteriously located placenta, and nociceptor activation may also be the cause of my crampy abdominal pain radiating to my back. My risk factors of third trimester and multiple pregnancy concur with this disease.
Neurologic symptoms are ruling out factors because abruptio placentae usually don't have those. To confirm this diagnosis, we need an ultrasound, Professor.
Very good, all of you. From your differentials, what do you think is the complete and final diagnosis? Harry?
Professor, it's placental abruption probably secondary to alpha thalassemia.
Explain how that came to be.
Well, Professor, after the discussion earlier, accidents in pregnancy like abruptio placentae is considered. This occurs when the maternal vessels anchoring the placenta rupture, causing blood to accumulate in the deciduum bassalis.
Persistent bleeding leads to either partial or complete separation of the placenta, activating the nociceptors, resulting in abdominal pain radiating to the back if the placenta is located posteriorly. This continuous separation induces uterine contractions, which manifested as abdominal tenderness. When the placenta completely separates, accumulated blood exits the uterus, causing profuse vaginal bleeding, which resulted in maternal hypotension. Due to this separation, the uteroplacental underperfusion affected the fetal gas and nutrient exchange, making the fetus tachycardic to compensate.
Thalassemia can be associated with placental abruption. The presence of long-standing anemia and chronic hypoxia in alpha thalassemia predisposes the mother to have uteroplacental hypoxic damage and eventually placental abruption. The history of alpha thalassemia and the risk of African descendants can lead to HbH disease.
Hemoglobin H disease is an autosomal recessive disorder where the deletion mutation of 3 out of 4 alpha-globin alleles produces insufficient alpha-globin chains, leading to ineffective erythropoiesis.
This will now cause moderate anemia with microcytic hypochromic RBCs and anisopoikilocytosis, leading to increased cardiac output to maintain oxygen delivery. Because of this, left atrial enlargement and tachycardia manifested in our patient. Chronic hypoxia may ensue due to impaired oxygen delivery, inducing uteroplacental hypoxic damage, leading to rupture of maternal vessel.
Repeated blood transfusions due to anemia explains the blood type chimerism. Thalassemia also allows the loss of ABO blood group antigens, which explains the blood type change from A to O. A complication of thalassemia known as spinal extramedullary hematopoiesis, presenting as pseudotumors in the spinal canal, caused spinal cord compression, which explains the neurologic symptoms and back pain.
Von Willebrand disease is another possible contributing condition that led to my demise.
Given your African descent and your O blood group, you had lower levels of factor VIII and VWF, which caused the excessive bleeding due to impaired platelet plug formation. This impairment in the intrinsic pathway manifested through your prolonged PTT.
The thrombocytopenia in thalassemia and impaired intrinsic pathway in von Willebrand's disease eventually led to coagulopathy, contributing to your profuse vaginal bleeding from the abruptio placenta and to the disseminated intravascular coagulation, which explains your postpartum hemorrhage. That is why even after your hysterectomy, you still had persistent bleeding, which resulted in hypovolemic shock and eventually your death.
What do you think the cause of my death was?
The immediate cause would be intraoperative hypovolemic shock. I'm just sure of it.
Hysterectomy and DIC would be the antecedent cause then, right?
Yeah, and abruptio placenta was the underlying cause.
Other significant causes contributing to death would be alpha thalassemia and von Willebrand disease.
Case closed.
Q&A portion of this online CPC. We have now the House of Gryffindor, and with us there are one member of our esteemed Board of Judges, Dr. Alvarado, ma'am. Good morning.
Morning.
Yes, ma'am. Dr. Alvarado, ma'am, you may now start the Q&A portion, ma'am.
Okay, to any one of the members of the House of Gryffindor, you have at least 5 serious conditions that you attribute as contributory factors to your final diagnosis of abruptio placenta. What is the common denominator that will account for the patient's demise? And a side question, is abruptio placenta an all-time fatal event?
Common denominator for the pathophysiology of all the disease condition is the coagulopathy. The abruptio placenta can be fatal, but can also be resolved. However, for this patient, the patient already has a deteriorating condition, and a contributing factor of hemoglobinopathy is contributing factor to the patient's demise.
Again, your patient has left ventricular hypertrophy, cardiomegaly, atheromatous aorta. Can you tie up these findings to your 5 conditions, namely uterine rupture, placenta previa, abruptio placenta, thalassemia, and von Willebrand's disease? Anybody from Gryffindor?
So for the left atrial enlargement, we can attribute it or associate it with our left ventricular enlargement. We can associate it with our thalassemia, since the patient compensates for the anemia through increasing the cardiac output to maintain the oxygen delivery. So it is seen in our patient as left ventricular enlargement.
How about your atheromatous aorta? Which condition?
For the atheromatous aorta, we have not included that particular manifestation in our diagnosis, but we can assume that the patient has a family history of cardiovascular disease and hypertension. So maybe the patient can also present with those disease conditions as well.
Okay, because reviewing from your chemistry, apparently you have essentially normal and or even low predisposing factors. You don't have any lipid profile. So anyway, we'll take it as that. And how about your von Willebrand's disease? Could you tie up with those cardiovascular findings?
So, Doc, the von Willebrand's disease is the patient's issue in their bleeding factor. So, because of the patient not being able to coagulate their blood properly, this contributed to the patient's demise of excessive bleeding. Now, because the patient has bleeding and has a bleeding issue and a hemoglobinopathy, this contributed to the patient's hypoxia as well, which contributed to the abruptio placenta.
I was trying to have an association with your cardiac findings. It's okay with the but you have not answered my my question. Does it have, that this have something to do with endothelial damage? That is my
No, Doc, but this would require the patient to overcompensate by increasing the heart rate because the regulation is compromised.
Anybody? Do you want to ask help from your other group mates?
Doc, according to a study we found, among von Willebrand disease patients, there's no effect of for the treatment of von Willebrand's factor concentrates on the intima or media thickness or the plaque score of the patient. So actually, it is actually having that disease is actually protective from development of atherosclerosis po, Doc.
Okay. Are you contented with your answers, or do you still want to add something more? Some more. Okay, let's go to the next set of questions. You have laboratory examinations, particularly blood chemistry, which shows a general electrolyte imbalance. Hyponatremia, di ba? Hypokalemia. Can you safely consider a third space loss as well, on top of the hypovolemia brought about by the bleeding? Of course, your patient was bleeding. If so, what organ system could be greatly affected? Anybody?
For the third space loss or third spacing, it can occur when there is too much fluid from the intravascular space or your blood vessels that leaks out. So it can potentially cause serious problem, particularly to your heart, since it can cause edema and your reduced cardiac output and hypotension. So the heart should compensate for those complications of your third spacing.
And what is the organ system that is greatly affected for this third space loss?
The organ system that could be greatly affected would be in the patient's cardiovascular system po, is heart niya and blood vessels.
Can you elaborate further?
Since po, there is too much fluid that would move about, syempre, of course, the patient's CVS system would have to compensate. So there could be effects on the patient's CVS and heart, such as the patient's heart rate para mag-compensate siya for the reduced cardiac output, and also the patient's hypotension if that happens.
Remember, third space loss is it's not intravascular. It's extravascular. That's why I'm asking for. That's why I invoke the electrolyte imbalance because of your hyponatremia. What happens there? What happens in your intravascular space? What happens with your extravascular space?
Can it also affect the renal system, since the body will assume that the fluid inside the body there is a loss of volume inside the body, so the renal system should compensate, so it can be affected by the third space law, hence the electrolyte abnormality.
So I would like you to pick up your choice. Which organ system is greatly affected? Is it the cardiovascular or the renal?
The renal, since we are dealing with the fluid balance inside the body po.
Are there other ideas or views which could add up to the relationship between the electrolyte levels, which are obviously abnormal, and the association with the third space loss on top of your hypovolemia? How about the perfusion? Perfusion of your vital organs. Kasi wala ka na dun sa wala ka na dun sa intravascular mo. Nasa labas ka na. So the third space becomes the the useless repository of your fluids.
All right. So actually, the time's up already, ma'am.
Oh.
Thank you so much to the students for a quite interesting exchange of knowledge. So thank you so much, doctors. You may now leave the platform. And may we request Dr. Alvarado, ma'am, to kindly stay behind for RTD po. Thank you.
Okay. Apparently, the students have a nice grasp on the case, but I think they are they still lack the pathophysiologic rationale. So I think it's on them. They have to read more. But then this is a very nice and a very challenging activity. Actually, this is a pioneering activity, which is very if I may say appropriate for our condition now, our learning experience. The thing is, we have to inject to our students independence on their reading and learning capabilities. It is this time that we should do away with spoon feeding and with lectures, because we have to engage them, but the brunt on us is that we should be all knowing, because if we cannot address their problems, that will be a devastating that will have a devastating effect on their search for knowledge. So this actually is a very nice venue for shall we say questions regarding medicine. It's not only medicine. Kaya pag natapos nila ito, ang problema na lang is to develop their skills, clinical skills, how to get blood, how to perform autopsy, and then while they are performing the autopsy, how they could associate their stock knowledge from reading to these cases. I would like to congratulate Dr. Ritualo for this case, because actually this is a case that is shall we say common in the country of origin of the patient, but rare in the Philippines. So this is a first-hand case, as Dr. Ritualo has told me, and actually he did the autopsy, right? Dr.
Right,
Ritualo.
right. Did the postmortem.
So we have we have the original we have the source who can guide the students.
Yes. Okay. So thank you very much, Doctora, for your time. Thank you, Doctora. Thank you very much.
Thank you so much, Tara. Thank you po.
The House of Hufflepuff will be judged by Dr. Jericho Cordero. This house is mentored by Drs. Ian James Tope, Redelia Nicolas, and Drs. Edith Freya. Our guest mentor for this house is Dr. Carla Maria Cesara from the Department of Internal Medicine.
Driving, gliding, living it up to the beauty. Got luck on with greater shares, gonna cheer yourself, it's so witty. Visit Saint Cynthia, visit Saint Cynthia. Don't believe me, just watch.
Once upon a time in the era of wizards and magic, there lived a poor muggle in the non-magical land of Berkshire,
cursed wizard bloodline as they were banished from the land of magic. As a new life transcended into her form, the family searched for ways to save the pregnant muggle until they heard about the most powerful wizard of Hufflepuff and one of the 4 founders of Hogwarts School of Witchcraft and Wizardry, Helga Hufflepuff. Wizard Helga appointed one of their best 4 heroes, exceptionally skilled and very powerful wizard of his time. He's a Scamander for the cause. Hufflepuffs are known for their hard-working, patience, fairness, justness, loyalty, and modest nature. Since Hufflepuff were known to value everyone and treat them as equal, the Muggle goes to the Hufflepuff wizard because she knows she will be treated as needed without prejudice, though she was just a Muggle. Just as they started their journey to the faraway land of Hogsmeade, Platform 9 3/4 from the King's Cross station was the only passage to the Hogwarts Express. He took her to the Hufflepuff house, where they all came together to discuss how to save the poor lady. Wizard Beezus brought the Sorting Hat to the Muggles' aid in the Chamber of Secrets for further investigation. Now let's see how the wizard examines our Muggle.
Earlier today, we received information of a Muggle who visited the Hufflepuff seeking help. So what do we know about this Muggle? What's the mystery behind her case? I, Wizard Jhansi, will be taking you further into the details. So here we have a 27-year-old African female pregnant at 38 weeks of gestation with a gravida of 4 and parity of 5. She came with the chief complaint of vaginal bleeding. Now let's look into the salient features. The salient features include hospitalization due to vaginal bleeding, multiparity, persistent anemia, lack of regular antenatal screening, and antepartum vaginal bleeding.
Aborto historica. Through present illness of patient 12 RPTA with crampy abdominal pain radiating to back within 10 minutes of interval. 1 RPTA with vaginal bleeding with bilateral lower limb weakness and twitching and jerking movement. On admission, tachycardia, fetal heart tone 180 bpm, massive vaginal bleeding. There is 10 units of FWP transfused within 48 hours. On third day, developed abdominal cramp with uterine contraction resulting in delivery. Obstetric history menarche at 12. Regular menstrual cycle 6 to 7 days. With dysmenorrhea, heavy blood flow. All birth by anesthesia, female Joe, G4P5, both older infant twins die after birth. Past history of hospitalization for anemia since childhood and regular blood transfusion. Socioeconomic history, poor socioeconomic status, nomads, gay tribes, had an eventual marriage with uncle. Family history with cardiovascular disease, diabetes mellitus, multiple myeloma in father, thalassemia in father and mother, anemia, malaria with falciparum. Review of system. There is dizziness but no headache. There is no numbness but muscle cramp. There is no blurring of vision but involuntary jerking movement of lower limb. On physical examination, she is tachycardic. Her vital signs of BP show 90 by 60 mm Hg, pulse rate 102 bpm, vagina, profuse vaginal bleeding with 50 to 100 ml. On neurologic examination, equivorous posture of the ankle, hyporeflexia and sustained ankle tonus of knee, DTRS symmetric +2. The lower limb strength assess the pain and spasticity, frequent arrhythmic metonic jerks.
Now that we've looked into our history and physical examination, let's look how imaging and labs can help us with our diagnosis. Wingardium Diagnostica. So from the CBC, we see that the hematocrit and hemoglobin are decreased, which are indicative of anemia. So the RBC indices shows us MCV is decreased, indicative of microcytic anemia. MCH and MCHC are also decreased, showing hypochromia. RDWCB is increased, indicative of anemia or nutritional deficiency. The platelets are decreased, indicative of thrombocytopenia in the patient. The peripheral blood smear shows microcytic hypochromic red blood cells with anisopoikilocytosis, suggestive of thalassemia. The differential count seems to be unremarkable. So from the coagulation studies, we see that the PT and APTT are both prolonged, indicating a coagulation abnormality. So from the blood chemistry, we can see that sodium and chloride are decreased, whereas magnesium and phosphorus are slightly elevated. So as we can see over here, the AST, LDH and globulin are increased, whereas the albumin is slightly decreased. So let's look into the imaging now. The X-ray seems to show some amount of pulmonary edema, which is suggestive of an emboli in the pulmonary circulation. So now let's move on to see what the ECG readings show us. So as we can see, flattened T waves are likely due to hypokalemia that is seen in our patient. Okay, so now let's see how our patient presented in the ward. On the third day following her delivery, she had persistent vaginal bleeding, approximately 2000 ml. She was transfused with 14 units of fresh whole blood, but she continued to have persistent bleeding. She was then scheduled for a hysterectomy, which is now being carried out.
However, the patient suffered cardiac arrest and died intraoperatively. So, this makes us doctors responsible to investigate. And this seems to be uterine atony causing postpartum hemorrhage, which led to the hypovolemic shock of the patient. Expecto impression.
Why don't we look at other possibilities? Alhambra diagnosis. The first one here we have is uterine atony. We rolled it in because it's the most common cause of obstetrical hemorrhage, multiparity, and large fetus, and we ruled it out because of antepartum bleeding and no postpartum exam findings.
And now we have to rule in uterine rupture because in addition to the previous hemorrhagic features, there is a presence of abdominal and back pain, and considering that the patient is from a low socioeconomic status, it qualifies us to have uterine rupture to be ruled in. However, we ruled it out because there was a lack of imaging and postpartum physical exam.
The next one we have is abruptio placenta. We ruled it in for third trimester vaginal bleeding, profuse postpartum hemorrhage, hypotensive, tachycardia, fetal distress, abdominal and back pain, tender abdomen palpation, and multiparty. We are not able to rule it out completely. And the last one, disseminated intravascular coagulation. We ruled it in for placental abruption, repeated transfusions, thrombocytopenia, postpartum hemorrhage, signs of shock like hypotension and tachycardia, positive neurological signs, and prolongation of the prothrombin and partial thromboplastin time, and we are not able to rule it out completely.
Avada Kedavra diagnosis. Alright, so that brings us to the diagnosis of disseminated intravascular coagulation secondary to abruptio placenta. The abruption of placenta led to disseminated intravascular coagulation, which was followed by formation of uncontrolled thrombin, which led to the formation or collection of fibrin in the microcirculation. So this manifested as pulmonary edema in the X-ray and other neurologic manifestations. The consumptive coagulopathy, in addition to the diffuse bleeding caused by the excessive transfusion and the surgery, led to hemorrhagic shock, which led to the cardiac arrest of the patient.
Unfortunately, the patient has already died, for which we could have done the additional testing, which includes a physical examination like checking of postpartum vital signs, examining of lower genital tract for possible lacerations or hematoma, and check if uterus is contracted and globular to rule out the atony. Lab test includes a complete coagulation profile for fibrinogen concentration and D-dimer test in which elevated levels of D-dimer levels are suggestive of clot formation in disseminated intravascular coagulation or DIC. Imaging includes the ultrasound, abdominal CT scan, head CT scan, and CT-guided pulmonary angiography. Antenatal ultrasound is to check for fetal well-being and to rule out placental abnormalities, and postpartum ultrasound to check for retroplacental hematoma. Abdominal CT scan to rule out the uterine rupture, head CT scan to rule out the stroke, and CT-guided pulmonary angiography to rule out the pulmonary embolism. If in future we come up with the same kind of case, then we can do the following management. Insert the two IV lines with crystalloids and colloids, transfusion if necessary, and give oxygen 6 liters per minute, insert a urinary catheter, and give fresh frozen plasma 1 unit per hour. Cryoprecipitate to replace fibrinogen if fibrinogen is less than 100 mg per dl. Platelet concentrates if platelets are less than 10,000 to 20,000 per microliter, and sometimes heparin. Also check for the follow-up like blood pressure, pulse, bleeding, hourly diuresis, CBC, clotting profile every 2 hours, and prophylactic antibiotics like ampicillin IVT 2 grams may be used. There was a change in blood type in the patient while doing the transfusion, which could be because of chimerism. This case qualifies therefore for artificial chimerism, which is secondary to massive blood transfusions in childhood.
So finally, we conclude with the cause of death. So the immediate cause of death being hypovolemic shock due to postpartum hemorrhage.
Antecedent cause: disseminated intravascular coagulation.
For the underlying cause of death, we took abruptio placenta leading to consumptive coagulopathy.
Other factors include the anemia, thalassemia, massive transfusion, major surgery, multiparity, and macrosomia.
That brings us to the end of the case presentation. Thank you.
Dr. Cordero, sir, you may go ahead now.
Anybody can answer this one, but before going to that, I would like to congratulate you. I've seen the ABP. I could see your efforts. Congrats on that. Okay, anybody can answer. Again, please state your main diagnosis. Anybody?
Dr. Our main diagnosis is placental abruption leading to DIC and eventually causing postpartum hemorrhage and hypovolemic shock.
Okay. As doctors, we all know that everything that we do practically, it has to have a so-called basis, preferably, of course, scientific basis. Now, you mentioned in here uterine atony. Okay, before going to that, I would like you to go back to your to the other details, particularly that before doing the physical exam. What are these? The chief complaint, the HPI, what else? The maternal history, family history, and socioeconomic history. At that point, doctor, for example, you have those details. What are your considerations? What are your impressions? Can you please share? So this is a point wherein you don't have the physical exam yet, you don't have the laboratory yet. What you had are those information. Again, chief complaint, the HPI, OB or maternal history, and so on and so forth. Anybody, please. What is your impression?
Even before, doctor, even before we examine the patient, as soon as we heard about the history.
I don't hear.
Can you hear me?
I'm having problem with the audio.
All right, doctor. So even before we examine the patient, as soon as we heard about the history and the background of the patient, we prepared ourselves for the worst case scenario because we know that prenatal care is really important. But considering the socioeconomic status and the background of the patient and from where she came from, we already prepared ourselves for the worst case scenario based on the statistics on how the prognosis would be when a person from that background is in the room for delivery. So we already prepared ourselves for those worst case scenarios. So that's how we started the approach for the patient.
Okay, point well taken regarding the preparedness. But at that point, what were your considerations? When we say consideration, I'm after the so-called impression or initial impression. Of course, not the final diagnosis yet, but at that point, what was your initial impression? Because your initial impression would reflect on the management that you will be doing at that point. Anybody, please.
Yeah, doctor, we think our initial impression would be regarding something related to a hematological disorder because like in the past history also the patient had a childhood anemia and she had undergone multiple transfusions because of that. And also she had a family history of thalassemia too. So we thought like there would be a major hematological disorder related to the profuse bleeding. So that's the initial impression we first considered.
Okay, point well taken. I've heard that very well. Okay, now let's put this time details such as physical exam and the laboratory. Okay, so you have now all those details, chip complaint, HPI, etc., until the laboratory and of course the physical exam. Now tell me, what is your impression at that point? Anybody?
At that point, doctor, when we ruled out, when we heard, when we had the physical exam and the laboratory, we were able to rule out the the other the other common causes for the presentation. For example, we ruled out the genetic causes, and we were now more focused on the hematologic causes, as mentioned before, and we were able to narrow the diagnosis and the reason for the manifestations as solely as the hematologic, because we saw the decrease in the major parameters in the CBC. So we were able to narrow the diagnosis and the reason for all the manifestations solely as the blood disorder.
Okay, I'm happy that you are always, well, twice you mentioned about the hematologic consideration. By the way, in terms of hematologic consideration or as an impression, what specific impression or disease process were you considering in here based on the so-called, what you said a while ago, hematology?
Doctor, we were looking into more of a coagulation disorder.
Okay. Anything else aside from that?
From the presentation, doctor, we knew that there is a deficiency. So the first thing that we knew that there was something deficient that caused all the symptoms on the presenting in the patient. For example, if there was an atony, then we know that there is something deficient that caused that. So in that case, there is a deficiency in a nutrient or the oxygen that the blood carries to the uterus that caused all the manifestations. So going back to the results, we knew that we saw that there's a decrease in the hemoglobin, the hematocrit count. So we knew that there is a deficiency in the blood that caused all those symptoms. So that's how we narrowed our, we knew that there's a presence of anemia that caused all those manifestations.
Okay. I'm glad
Doctor,
that
we also
yes,
considered it could be a bleeding disorder as well. So as also she had a family history of hematologic disorders. So we were thinking maybe hemophilia, or also because her AST
I'm sorry,
was slightly
hemophilia and what,
increased.
doctor? Hemophilia and what? Can you please repeat that? You were
We thought of
considering hemophilia and?
we thought of just hemophilia or von Willebrand's disease, because her PT and APTT were increased. So that's why we went in the direction of DIC, since both of them were prolonged.
Okay, let us go to the laboratory workup, particularly the so-called morphology, the blood picture. And any comment on that? Can you please give me an interpretation of that laboratory in relation to your case?
Doctor, the first thing we see is, but I'd like to take this question. The first thing we see is that she has some sort of microcytic anemia. So based on her family history of thalassemia seen in both her parents, there's a likelihood that she also might have thalassemia, but we're also looking into the fact that she was from a low socioeconomic status, and also her history of profuse menstrual bleeding could have caused her to have iron deficiency anemia. So either of those could have caused her microcytic anemia.
Okay, very good. You mentioned DIC, hemophilia, even thalassemia. If you have that consideration, can you give a summary on how to do a workup on this? Can you please give us an idea how we can come up or differentiate those three diseases?
Yes, doctor. For hemophilia, there would be mostly only an increase in the PT, because it usually shows dysfunction in the intrinsic pathway of the coagulation system, whereas DIC goes in the way that it affects the common pathway, and it also causes thrombosis and bleeding. So over there, you usually see an increase in both PT and APTT, even though in hemophilia, in the long term, it could lead to an increase in both. But in an acute setting like our patient, probably not. So that would differentiate it. Then we can also ask for other labs like fibrinogen levels and also D-dimer levels, because you wouldn't see clotting in hemophilia, whereas you would see clotting and you would find D-dimer levels to be high in DIC.
Okay.
1 minute. 1 minute.
1 minute, sir.
Yeah, 1 minute left.
Okay. Okay. So I'm wondering, of all these hematologic abnormalities or conditions that you mentioned, which one would you put on top as a primary consideration, and why?
For us, I think DIC itself, because of her various presentations, because as we saw that she showed some neurologic presentations as well, but we couldn't identify what would cause it. So our process of thinking was most likely an intracranial hemorrhage or a microthrombi. Also, the other things is that she presented with antepartum bleeding and postpartum bleeding. So abruptio placenta would present with bleeding in both those cases, and also it has a complication of leading to DIC. So in that way, we connected all of these symptoms and presentation and led to us thinking that it could be DIC.
Okay. How many minutes do I have, sir?
Time's up. Time's up.
Thank you. Thank you very much, doctor. Congratulations, doctor.
Thank you, doctor.
Dr. Cordero, sir, may you please share with us your opinion with regards to this CPC case, for this case?
Yes, ma'am. Good morning again po. The discussion for me centers about the so-called postpartum hemorrhage. If you would notice, I was trying to extract from them the possibilities of a so-called postpartum hemorrhage, and I was trying to dig in to the so-called to that important data, and that is the family history. For the record, when we have a so-called postpartum hemorrhage, there are 4 letter T's. No? What are those letter T's as a cause of postpartum hemorrhage? One letter T is, of course, uterine atony. Next is the letter T is trauma. So I think they mentioned about that, abruptio. Next is rupture. Next is letter T is the tissue. Placental penetration, and fourth, I think it's thrombi or thrombin. Of the 4 letter T's, they were somehow concentrating, or should I say, they mentioned the 2 T's, the trauma, and as well as the thrombin aspect of it. But that's why when I asked them, among the 3 hematological considerations, which one is the so-called primary, and they still said it's still DIC. So probably looking at the history wherein there is thalassemia, history of thalassemia in the family is a major clue. That's my comment only, sir, ma'am.
Okay, Doc Rick, thank you very much for your, again, short notice.
Sir.
Anyway, Doc Rick, thank you very much. Thank you very much. And, we will meet someday again kapag wala na siguro ito pandemic. Thank you.
For the House of Ravenclaw will be judged by Dr. Leonisa S. Sagon. This house is mentored by Drs. David Brian Olveda, and together with our guest mentor from the Department of Obstetrical and Gynecology, Dr. Rodolfo M. Pascual.
Ravenclaw! Ready! Let's go, Ravenclaw! Let's go! Let's go, Ravenclaw! Let's go! Ravenclaw!
We are the champs, we hold the key. They call us ravens, we have no fear. Are you ready? Hey, we are ready, Raven face. Ha! Give us the kicks, rah rah, Ravenclaw, ahoo ahoo.
Previously on Grand CPC 2021, knowing that Alex was in love with Joanna, they put a curse on Monica's baby. Causing it to have hydrops fatalis, but that wasn't enough for them.
We're losing her!
What did you do? Look what happened to Monica!
No, she had it coming. You haven't even finished the ritual yet.
Stop arguing! Let's just solve this case first and we'll deal with your punishments later.
Okay, let's view her chart. She's a 27-year-old African female, 38 weeks AOG, G4P55001, with a chief complaint of vaginal bleeding. 12 hours prior to admission, she presented with crampy abdominal pain, radiating to the back with a 10-minute interval. Then 1 hour prior to admission, vaginal bleeding was noted, accompanied by painful bilateral lower limb weakness with muscle cramps, sudden twitching, and jerking movements. She had no previous surgical procedure, but has a history of regular blood transfusion due to persistent anemia.
Well, the patient was tachycardic and there was massive vaginal bleeding, hence her admission. Fetal heart tones were 180 beats per minute. Her serum electrolytes were normal except for potassium at 3.0, and her CBC revealed low hemoglobin and hematocrit. Her blood type showed that she was an A positive, so they ordered 5 units of A positive, but then they repeated the blood typing and also did cross-matching, and the patient was found to be O positive instead of A positive.
So it says here that a blood typing procedure investigation was done, which revealed no breach in the blood typing protocol.
10 units of type O positive fresh whole blood were ordered, and 5 of those were transfused within 24 hours. The remaining 5 units were transfused the following day, but her hemoglobin level remained lower than normal despite multiple transfusions. On day 3, the patient delivered a full-term 5.5 kilogram male infant with an APGAR score of 5 at 1 minute. The infant expired after 2 minutes, and patient's bleeding was controlled subsequently.
She already had 5 previous pregnancies. She had twins, which were delivered by normal spontaneous delivery or NSD by a female zoo, and both twins died after birth.
Christina, you told me that she had the previous history of change in blood type. Does her chart say anything about her childhood hospitalizations?
Yes, actually, it says here that she was regularly hospitalized for anemia since childhood, receiving regular blood transfusions. However, the amounts were not noted.
Oh, I remember this one. I think it's something called chimerism. I think the change in blood type has something to do with that. It has connections with regularly receiving blood transfusions and a family history of twins, right?
This is interesting. She is second-born, and 2 of her siblings were twins, which died at an early age. She has undergone clitoridectomy, adopted by her uncle, and became one of his brides.
She also has a family history of cardiovascular disease, diabetes mellitus, multiple myeloma, thalassemia, and anemia, and also malaria.
Wait, I remember from a previous CPC that it was established that she also has alpha thalassemia HbH disease. It also says here that she's been feeling dizzy and having muscle cramps and involuntary jerking movements in her lower extremity.
On general survey, she was conscious and alert, but massive vaginal bleeding caused admission. Vital signs were within normal limits except for tachycardia. Her HENT and physical exam were unremarkable, but abdominal PE showed tenderness on palpation. On inspection of the external genitalia, her clitoris is absent from previous clitoroidectomy, and PE of the vagina showed a rugated vaginal wall with profuse bleeding, and her cervix was soft and slightly opened.
Her neuro findings also showed an equinovarus posture of both ankles, bilateral hyporeflexia, and sustained left ankle clonus, but lower limb assessment was limited due to pain and spasticity, and there were also frequent myoclonic jerks and ankle clonus.
Her CBC revealed anemia, thrombocytopenia, and eosinophilia. PT and PTT is slightly prolonged. She has mild hyponatremia, hypoalbuminemia, but her magnesium, phosphorus, AST, and globulin are above normal.
She developed persistent severe vaginal bleeding of 2 liters, and 14 units of type O positive fresh whole blood was immediately transfused in 24 hours, but the bleeding persisted and a ruptured blood vessel was considered. An exploratory laparotomy and hysterectomy was scheduled and carried out, but unfortunately, during the actual procedure, the patient suffered a cardiac arrest and expired intraoperatively.
What? 14 units? That's considered a massive transfusion. Did she have a chest x-ray?
Wait, here's her x-ray. It doesn't show any signs of pulmonary vascular congestion though, just a aromatous aorta.
How about her ECG?
The leads V4 and V5, which represent the lateral wall, show flattening of the T-wave.
Wait, you have to remember that this patient had anemia induced by thalassemia since childhood, so that's a possible ECG finding.
What could her diagnosis be?
With the patient's chief complaint of vaginal bleeding? How about uterine rupture? Do you guys think that it could be a possible diagnosis in this case?
Yeah, I think so, but what are your other reasons for considering this diagnosis?
Our patient also presented with abdominal pain radiating to the back. This is a common presentation in patients with uterine rupture. Also, she was noted to be hypotensive and tachycardic. This could be also due to the severe blood loss caused by uterine rupture. She was also from Africa, where uterine rupture is the leading cause of maternal death. Other factors such as multiparity, rural residency, abdominal fetal presentation, and macrosomia were also significant risk factors in this condition.
But it was mentioned in the patient's OB history that all of her prior pregnancies were delivered via NSD, right? So if there were no prior CS deliveries, no other history of surgical procedures, I think we can rule this out since a scarred uterus is a common risk factor for uterine rupture. What do you guys think?
Yeah, I agree. And our patient was just 27 years old. Women aged 30 years or older have a greater risk.
So if uterine rupture has been ruled out already, do you have any other diagnosis that could lead to vaginal bleeding in this patient?
Well, let's see. Given the vaginal bleeding, crampy abdominal pain, could this be a case of abruptio placenta? Well, to elaborate on clinical manifestations, vaginal bleeding is present in most cases of severe AP. She has tachycardia, dizziness, hypotension, which could have been caused by the blood loss due to premature separation of the placenta from the uterus. She had postpartum hemorrhage and other risk factors like increased parity, low socioeconomic class, delivered male infants, and for her lab findings, the patient had a decreased platelet count and elevated PTT, which is suggestive of AP.
I don't know. I'm still not convinced. Hear me out. The patient didn't have maternal hypertension, preeclampsia, or eclampsia, which are major risk factors. No advanced maternal age, alcohol consumption, smoking, nor previous abdominal trauma. Most importantly, she did not have a prior history of previous abruption.
I still feel like it cannot be totally ruled out, but Kylie, you have a good point. What do you think it is?
Aha! Don't you think this is a case of uterine atony?
But how do you say so?
Look, after the delivery, Monica developed persistent vaginal bleeding of 2 liters. She's also hypotensive and tachycardic.
You sure? I mean, she was just 27 years old. It's usually women aged 35 years or older who have a greater risk of uterine atony. Also, there was no previous history.
No, wait, there's more. Let's not forget that she is multiparous with fetal macrosomia. She had a history of twin gestation and DM in the family. These are all risk factors for uterine atony. Because of this, Monica is bleeding after birth, and this resulted in the decline of the RBC indices. Remember, 90% of postpartum hemorrhage is caused by uterine atony. Believe in me now?
Oh my god, you're right, Kylie.
This is great, but I still have one question. How does all of this lead to Monica's death?
When Monica felt that crampy abdominal pain all the way to her back, together with the vaginal bleeding 12 hours prior, she didn't realize it was already placental abruption. That means her blood vessels which anchored the placenta have already ruptured, and as it worsened, that was when the vaginal bleeding was seen. A few hours later, other symptoms like the painful bilateral lower limb weakness, the myoclonic jerks, and hyporeflexia started manifesting, probably because of more blood loss brought about by the partial separation of the placenta from the uterine wall as more time passed. Not only that, but she also had organ hypoperfusion due to her hypotension and anemia.
So the placental abruption would also explain the elevated LDH levels, besides the fact that she has alpha thalassemia HPH disease and that she's pregnant. And there was flattening of P waves in her ECG since her potassium levels have reached the lower limit due to the blood loss.
Yes, also her placental abruption prompted a disseminated intravascular coagulopathy. Her initially contained bleeding would release tissue factor thromboplastin into the maternal circulation, activating the external coagulation cascade and cause the DIC, which is why ischemia and hypoperfusion ensued. The ischemia, along with the hypovolemia, became a significant contributor to the development of uterine atony, which caused Monica's postpartum hemorrhage.
She really had the uterine atony as well?
Yeah, bet. With Monica already having DIC as evidenced by her labs, her deranged clotting factors and platelet count, and her blood loss of 2 liters, resulting to that crazy massive transfusion of 14 units of fresh whole blood, combine that with the ischemia and hypovolemia, no doubt that Monica had uterine atony.
Realized that Monica also presented with several risk factors for uterine atony, like the known fact that she has diagnosed with alpha thalassemia HPH disease. The thalassemia led to development of anemia as evidenced by the microcytic and hypochromic red blood cells with anisopoikilocytosis found on her peripheral blood smear. I also remember that she regularly received blood transfusions for this during her younger years. I believe that thalassemia-induced anemia was also the reason for the presentation of tachycardia, hypotension, and dizziness. The hypoperfusion brought about the anemia, as well as her previous episode of blood loss and consumptive coagulopathy, may have caused hypoxia to the uterus, leading to the poor myometrial contraction. And aside from this, overdistension of the uterus is a major risk factor for atony. And in the case of Monica, she delivered a macrosomic fetus who weighed 5.5 kilograms.
Exactly. The exhaustion of the uterine tissues ultimately resulted in uterine atony. Since there was no contraction of the myometrium, the spiral arterioles were kept open and bleeding of the patient persisted. This caused the patient to enter a state of hypovolemia once more, and the disseminated intravascular coagulopathy, which started off mild and progressive during her antepartum bleeding, began to worsen due to the persistent postpartum hemorrhage and the massive blood transfusion of fresh whole blood.
So you mean to say if concomitant DIC is present, the uterine atony was further aggravated by her fetal delivery, which is why she bled further and got into this vicious cycle?
Poor Monica, the consumption of clotting factors and platelets in BAC resulted in this fatal hemorrhage.
Well, yes, the ruptured vessels that those clinicians suspected to be the cause of Monica's persistent bleeding, which sent her to a trip to the OR, all ultimately caused her death intraoperatively due to the massive bleeding and hypovolemic shock.
So it wasn't my magic or spell after all, it was something so complex and elaborate. Something we could have got early on so we could have avoided this terrible situation. So wait, let me see if I got this right. Monica's immediate cause of death was hypovolemic shock, and the antecedent cause was perioperative complication of disseminated intravascular coagulation, and the underlying causes are uterine anatomy and abruptia placenta.
Exactly. Don't forget the other significant factors causing her death.
Oh yes, of course, alpha thalassemia, and as for the classification of maternal condition, the death was less than 42 days after delivery.
Oh, so everything makes sense now.
Now that we know what happened, it's time for your punishment, Christina and Joanna. Avada Kedavra!
No!
You may now start the Q&A portion. Thank you so much. Yes, ma'am.
Okay, okay. So, you have a very comprehensive and complete discussion, no? Congratulations, I appreciate that. But in your discussion, there was some mention about the explanation about the changing blood type. That's my first question. And the second is about the familial history, the presence of twins as one of their siblings or the patient siblings rather, and her twin pregnancies. Are these familial and maternal history relevant to your case? That's my second question. So, can you answer these questions, please?
Good evening, Doktora.
Yes, good evening.
Yes po. So for the change in blood type, we have three theories about this. It's all about chimerism. So first is the true chimerism, which it happens in twins. But and then the second one is mosaicism, which happens when there is dyspermy. And then the third one is artificial chimerism, which normally happens in like blood transfusions, or if there is transplantation of bone marrows, or exchange transfusions and fetal maternal bleeding. So in the case of our patient, it was mentioned that there was a in her siblings was twins, but wala po siyang kakambal. So, we're thinking that the chimerism or the change in blood type in the patient is caused by artificial chimera because of her multiple blood transfusion since childhood, which is because she is anemic po, Doc.
Okay. How about the second question? Have you answered everything? The twins, the siblings, her other siblings, which are twins, and her other pregnancies, which are also twins, and they both died early, no? Okay. Is this relevant to your case? Anybody?
Good evening po, Doc.
Yes, good evening.
So for the case of the twins in her history, most especially for her obstetric history, she did give birth to a set of twins, and we think this is very significant since high multifetal gestations and her high parity play a role into our final diagnosis and into her clinical course and she how her death came about into to the course of the patient's in the course of the patient in the wards. I'm sorry.
Okay, very good. How about the anemia? What is the etiopathogenesis of the anemia in your patient? Anybody?
Doc, regarding the anemia of the patient, it is anemia induced by the alpha thalassemia hemoglobin H disease of the patient po.
Okay. So that's all. That's other inputs from anybody of the group. No other additions. Okay. So these are all my questions to the group, and I am satisfied with all your answers. Okay. So that's it. That's the question and answer. Okay.
Thank you so much, Doctora. And thank you also to the members of the House of Ravenclaw. You may now leave the platform, doctors.
I'd like to congratulate everyone with their presentation. It was and very comprehensive. As in other clinical pathology conference, the accuracy of diagnosis is not important. Most is how you arrive at the diagnosis. In this case, the groups have satisfied excellently all these criteria. Now, my insights are the following. I'd like to start by explaining what is chimerism. No? So, true chimerism is the presence of two or more zygotes in all the tissues of the patient. So, the two cell lines are present in the fetus and in the embryo and the other tissues of the patient. Another is the confined chimerism. This is an admixture of two or more zygotes in one specific tissue of the body. So this may be confined in the blood. So we have the confined chimerism, best exemplified by bone marrow transplants. And in this case, we may have blood typing or HLA typing errors. And in some other cases, we have confined placental chimerism, exemplified in twin pregnancies. So these are only confined in the placenta. Now, what is the mechanism in confined type of chimerism? It is the anastomosis of the blood vessels between the mother and the fetus. There's also such a thing as microchimerism, no? So this is present in dizygotic twins, and it may be iatrogenic, as in multiple blood transfusions, stem cell implantation or therapy, other organ transplantation, and even in multiple transfusions. It is said that all Paros women have microchimerism, no? Because two cell lines are present in the circulation, that of the mother and that of the fetus. And it is also said that in some studies that fetal maternal cells have contributed to the repair of any maternal injury. So there's very few studies in literature because of the methods in which to confirm chimerism. And these are the molecular methods involving the fish method, so the interface fluorescent in situ hybridization and fluorescent PCR or the quantitative fluorescent PCR. So in all these methods, we require fetal and embryonic tissue sampling. So it's very difficult to study chimerism. That is why there are few studies present in literature. And chimerism is considered rare, but how do we know? It may be more common. So in our patient, I believe that she has both microchimerism and confined placental chimerism. And chimerism is also associated with autoimmune diseases. So it may be manifested in some forms of erythroblastoma fetalis, no? As may be in our patient. So these are all my insights for this patient. And I hope the learning process has been two-way. I've learned from the discussion, as well as I hope I have contributed a little to the knowledge of the presence of chimerism. And with this, I'd like to end my insights. And of course, I'd like to thank everyone for inviting me, especially the chair, Dr. Ritualo, and the consultant staff pathologists, and likewise the technical staff, because they have made this uh, highly creative clinical pathology conference possible. Okay, so that's it. Thank you and good evening to everyone.
That was so delightful and enjoyable presentations, and more so a very informative one. In line with it, we have invited a very special guest to give comment and share his expertise on the case. Our resource person is a medical doctor and a lawyer by profession and obtained his degrees from the University of Santo Tomas and Jose Rizal College, respectively. He is also a MBA candidate, Senior Management Program in MBA at Graduate School of Business, Colegio del San Juan, Tran. He also finished a postgraduate course in clinical pharmacology from the University of the Philippines College of Medicine. He also holds a master's in criminal justice administration from San Beda College of Law. He also had units on Master of the Laws from the same college. Our resource speaker has the following specialty conferments, with areas of expertise on healthcare, law and litigation, legal medicine, family medicine, pharmaceutical medicine, clinical pharmacology, drug research and clinical trials management, medical litigation, corporation law, medical pharmaceutical marketing, cooperative management, food and drug regulatory affairs, cooperative management, and currently he is a professor and the department chair of the legal medicine of the Jonathan Foundation School of Medicine. He is also a board reviewer in legal medicine, a member, the past chair of the Institutional Ethics Review Board of the University of Perpetual Health, Rizal Medical Center. Our speaker is a member of various organizations, and not to mention a long list of achievements. And without further ado, I would like to call on our well-respected guest speaker, Dr. Bienvenido Jose V. Chanco.
I would like to thank the Department of Pathology and Dr. Billy Ritualo for the invitation to this CPC to share my thoughts on the medical legal aspects of peri. The death certificate is a legal document wherein the peri-procedural aspects of a person's demise can, is, or should be recorded. For the purpose of this exercise, I shall make reference to the format currently used in the Philippines. Due to time constraints, I'll go to the meat of the document, which is the medical certificate portion. Deaths of infants 0 to 7 days are to be recorded in the back portion of the death certificate. But our focus for this discussion is the reportorial aspect of deaths 8 days or over. So this applies to older infants, to children, and adults. Since the topic is peri-procedural reportage of death, let's first have a bare bones concept of what constitutes peri-procedural mortality. Simply put, peri-procedural mortalities are events known or suspected occurring before, during, or soon after the performance of a therapeutic, diagnostic, anesthetic, or other medical procedures leading to death. Let's look at Section 19B of the current death certificate and focus our attention on the cause of death section. It's made up of two parts, Part 1 and Part 2. Part 1, in the order enumerated, lists as follows the immediate cause, the antecedent cause, and the underlying cause of death. Part 2 provides for stating other conditions contributing to death. Now, the current form that is currently in use only asks for information on the inclusive dates during which the patient was attended to. So the time he was first seen and up to the time the patient died. Now, there is a proposed format by DOH and PSA, the Philippine Statistical Authority, that expands on the previous. This asks for a more detailed time element from the underlying to the antecedent to the immediate cause of death. So the person looking at the document will have an idea of the time frame in hours or minutes that transpired from one cause to the next, leading to the person's death. Hopefully, this proposed form will be adopted soon. Based on the current reporting format and also on the proposed one, there is already a very procedural requirement in the reporting of death. So it is not really something new or out of the blue. The question really is it being done? And is it being done properly? Related to the question in the previous slide, do people know what to place in the peri-procedural causes of death? What if the reporter is not a physician? Or if he is a physician, is the person aware of how to do this? Unless the doctor is an oncologist or a neurologist with moribund, stroke patients, etc., not all doctors deal with death on a daily basis. For a dermatologist, death is not a commonplace in their practice. So it begs the question, are all doctors competent with regards to this very procedural concept? There is also this fear of litigation, that a wrongful entry in the document raises the specter of malpractice. So, right or wrong, to many, Section 19B may be a bomb that can explode in their faces. Now let's deal with the medical legal concerns. Based on the matters previously raised, this slide deals with some of the concerns that may be in the back of minds of physicians. Many have litigation phobia, probably from watching too many movies or too many TV series. But are these events really happening? Is that reality? Probably in other jurisdictions like in the US, it may be. But in our country, it may not be as widespread as feared. But the phobia can be wiped out from the doctor's mind if correct and factual reporting and case analysis is done. It also serves as a good CYB, or what we call cover your back defense. Now, another thing that we have to look into is, or answer, is the question of whether peri-procedural reporting needs training. Or for physicians, is peri-procedural reporting already a given, just like using a stethoscope? Now, the Department of Health and the PSA has recently come out with a manual to guide reporters on how to fill up forms using the peri-procedural approach. It guides doctors on the ins and outs of properly filling up the form. So this manual really should help the reporter. Now, just a comment. I believe that peri-procedural or not, a doctor who is in the dark as to the pathophysiological events occurring in his patients probably shouldn't even be practicing medicine. But that is just my opinion. There is also the other concern, and this concern involves non-doctors like nurses, midwives, etc., who are also at times tasked to fill up the certificate. Now, are these healthcare professionals adept with the peri-procedural approach? They may not be clinically astute compared to their medical counterpart, and for the reason that their training does not call for that. Also, is peri-procedural reporting applicable to all deaths? The death of a victim with a gunshot wound to the brain is clear-cut. Whatever medical condition the victim was suffering from is immaterial as to his cause of death. So, a clear enunciation of cause of death avoids confusion and suspicion. Reporter must use appropriate medically accepted terminology. The reporter should not be evasive. Put only what is needed in the report, because inadvertent omissions are magnets for complaints, may be magnets for complaints later on. Now, just to clear the air, the peri-procedural reporting, even if with errors, is not proof of malpractice. It still requires evidence to prove the fact of malpractice. So we just don't rely on the certificate. Now, the same is true when crime is suspected. It has to be investigated. You just don't make a conclusion based on the medical certificate. So, to refresh ourselves, the current format already provides for, in fact, requires peri-procedural reporting. If you will again look at the slide, part 1, which is the part 1, there is a requirement for stating the immediate, the antecedent, and the underlying cause. So this is really already need to be applied now. Now, in a nutshell, to further amplify on the immediate cause, it refers to the most recent condition that caused the person's demise. The antecedent cause is a less recent condition that contributed to the immediate cause. And the underlying cause is a previous condition which may have precipitated the death of the patient. Now, the other significant conditions contributing to the death refers to something else that may have contributed but did not produce the sequence in part 1. Now let's look at other death certificate reportorial considerations. You will note that 19C provides for maternal condition. The deceased may have a maternal condition that may be important and needs to, and that's why this part of the form needs to be filled up. So was the deceased pregnant, in labor or not, less than 42 days after delivery, 42 days to 1 year after delivery, etc. So this is on top of the previously discussed requirements on immediate, antecedent, and underlying causes. There is also a section on persons who attended the deceased. So the reporter likewise must be profiled. So is he a private physician, a public health officer, hospital authority, none, or others? So the others could mean other healthcare professionals, could mean law enforcement agents, etc. So as can be seen, some reporters may not be versed in the procedural aspect, especially those others, right? Or hospital authorities who may not even be physicians. Now let's discuss item 22 on the certification of death portion. It states that the foregoing particulars, or what has been filled up above, are true and correct as far as it can be ascertained. It does not mean that what is placed in the certificate has that aura of infallibility, or in other words, it is always correct. So this portion allows for correctable, honest errors. However, I would like to point out that error of any kind should always be avoided. That's why the reporter must be very careful and very sure of what is put in the form. Now, intentionally placing wrong data may constitute fraud, and that is no longer an honest error. Fraud is a crime under the revised penal code. There is also in item 22 a further certification whether or not the signatory attended to the deceased. Of course, in hospital settings, usually it's the attending doctor. Although, of course, as previously stated, the public health authority, hospital authority, others. And there is also a portion wherein the document is reviewed by the city health officer, the provincial health officer, the municipal health officer, or whoever. But the review is more to see to it that the document is in compliance with the form required, with the format. In other words, the items are filled up rather than the substance contained therein. Now, there is this question: should the reviewer be a pathologist and not just a bureaucrat like the city health officer or provincial health officer? Now, the problem with that scenario is that there are confidentiality concerns for which the pathologist may not be privy to the case. So, will there be a violation of confidentiality and privacy if a third party reviews the form? So that's a question that needs to be looked at. And of course, any reviewer may be implicated in case of foul play, intentionally fraudulent insertions in the form. Now, there is also that section on the informant. Well, usually this is filled up by the next of kin, and the information supplied by the kin are true and correct according to the reporter's knowledge and belief. So they will put there the particulars of the disease, like the day, the name, date of birth, citizenship. Usually, it's filled up by a next of kin or a very close relative or even a friend. Now let's look at false statement or false entries in the certificate. More so connected with the peri-procedural aspects of the report. Knowingly, intentionally making false statement and then presenting the same document for entry to the civil registry is punishable by law under Republic Act 3753. This is quite a very old law, and the imprisonment and fine may not be that severe because it's an old law. However, the false statement placed in the certificate may open the Pandora's box to other offenses that may have been committed with regards to the management of the patient or the person. So it may open up a case of malpractice, the crime may be discovered, etc. Now, all of these malpractice crime shall be dealt with independently of the error or false statement in the death certificate. So there's going to be a two-pronged approach in dealing with the offense. So finally, very procedural aspect of reporting is nothing new, and every doctor worth his salt should know how to fill it up, or should at least have an idea. Do they require further training? Maybe yes for some. For others, probably not, especially if they're already well versed in the pathophysiological events occurring or transpiring in the patients they just handled. So that ends my commentary on peri-procedural reporting of death, and thank you very much for your attention.
Thank you, Dr. Chanko, for sharing your expertise. We now move on to the second part of the competition, which is the MCQ portion.
Good morning. So these are the following participants to answer question number 1. Okay, so we have Capuno Brando from the House of Ravenclaw. We have Tetgure Adik Ramdas from the House of Hufflepuff. We have Velasco Twinkle from Gryffindor, and Banot Giri Sainath Naik from the House of Slytherin. Okay, Ma'am Janice, kindly verify the following students.
Yes, Doctora, they are all verified.
Okay, so this is question number 1. Students, please listen carefully. The following are true for adenomyosis except Letter A, the presence of endometrial glands in the endometrium. Letter B, common in women over 40 years of age. Letter C, seen in 40% in the uteri at autopsy. Letter D, causes uterine enlargement. Letter E, resembles leiomyoma grossly. Again, the following are true for adenomyosis, except letter A, the presence of endometrial glands in the endometrium. Letter B, common in women over 40 years of age. Letter C, seen in 40% in the uteri at autopsy. Letter D, causes uterine enlargement. And letter E, resembles a leiomyoma grossly. That's it. Time is up. Okay. And the correct answer for question number 1 is letter A. So question number 1, only House of Slytherin got the correct answer.
All right. So for this number, the house who got the correct answer is the House of Slytherin. Congratulations. Thank you, doctors. You may now leave the platform.
Okay. So for question number 2, the following participants are from the House of Ravenclaw, we have Serna Kim Martina. From Hufflepuff Group, we have Vera Mameni Kanakama Halakshmi. From the House of Gryffindor, we have Cervantes Mark Joshua. In the House of Slytherin, we have Shohan Tarun. Okay, students, please get ready. Okay, so question number 2. Endometrial polyps. Choose from the following letters. Letter A, common in menopause. Letter B, covered by endometrial epithelium. Letter C, composed of endometrial glands. Letter D, may show cyclic changes. And letter E, do not have a fibrovascular stroma. Again, endometrial polyps are one of the following. Letter A, common in menopause. Letter B, covered by endometrial epithelium. Letter C, composed of endometrial glands. Letter D, may show cyclic changes. And letter E, do not have a fibrovascular stroma. And the correct answer for question number 2 is letter E. Okay.
Alright, so for this number, nobody got it correct. You may now view your scores, doctors, after which you can leave the platform. Thank you.
Okay, so for question number 3, we have Valientes Katrina Atria from the House of Ravenclaw. We have Butla Harnada, Ready Ramya for the House of Hufflepuff. We have Mendoza Carlos Miguel from the Gryffindor and Esan Khalid from Slytherin. Ma'am Janice, kindly verify the students.
They are all verified, Doctora.
Okay, so let's proceed to the question. Okay, so for question number 3, which statement is true for alpha thalassemia? Letter A, results in decreased production of beta globin and resultant excess of alpha globin. Letter B, one gene abnormality with variable amounts of beta chain underproduction. Letter C, dysfunction of both beta globin genes. Letter D, deletion of one or more of the 4 alpha globin genes leading to beta globin excess. And letter E, cause formation of insoluble alpha tetramers causing ineffective erythropoiesis. Again, What statement is true for alpha thalassemia? Letter A, results in decreased production of beta globin and resultant excess of alpha globin. Letter B, one gene abnormality with variable amounts of beta chain underproduction. Letter C, dysfunction of both beta globin genes. Letter D, deletion of one or more of the 4 alpha globin genes leading to beta globin excess. And letter C, cause formation of insoluble tetramers causing ineffective erythropoiesis. You have 15 seconds to answer. And the correct answer for question number 3 is letter D.
All right. So for this question, all of the houses got it correct. You can now see your scores and then leave the platform.
Okay, for question number 4, these are the following participants. From the House of Ravenclaw, we have Reyes Conrad Alfred. From Hufflepuff, we have Panjel Mayur Sriram. From Gryffindor, we have Garduke Joshua. And from the House of Slytherin, we have Kaushik Surya Pratap. Okay. Again,
They are all verified, Doctora.
Okay. So we shall proceed to the question. Okay, so this is question number 4. The following concerning thalassemia diagnosis is true, except letter A, microcytic hypochromic red blood cells. Letter B, poikilocytosis. Letter C, anisocytosis. Letter D, splenomegaly may be the only physical manifestation. And letter E, presence of nucleated red blood cells. Again, the following concerning thalassemia diagnosis is true, except letter A, microscopic hypochromic red blood cells. Letter B, poikilocytosis. Letter C, anisocytosis. Letter D, splenomegaly may be the only physical manifestation. And letter E, presence of nucleated RBCs. Okay.
So all answers are in.
Okay, and the correct answer for number 4 is letter C.
All right. So for this number, unfortunately, no house got it correct.
Okay, no one got the right answer.
So you can see your scores in the scoreboard and then you may leave the platform. Thank you, doctors.
Participants for question number 5. We have Najar Michael Tari from the House of Ravenclaw. We have Sardar Ria Naresh from House of Hufflepuff. Duran Christian Joseph from Gryffindor. And Maheshwari Bhakti from the House of Slytherin.
They are all verified, Doctora.
Okay. Okay. Question number 5. True for hemoglobin electrophoresis except letter A, increased percentage of hemoglobin A2 and HbF for beta thalassemia. Letter B, silent carriers with single alpha chain loss have an abnormal electrophoresis. Letter C, those with HbH disease have a loss of 3 loci. Letter D is diagnosis is made by globin gene analysis. And letter E, HbH disease have increased beta tetramers. Again, true for hemoglobin electrophoresis except letter A, increased percentage of HbA2 and HbF for beta thalassemia. Letter B, silent carriers with single alpha chain loss have an abnormal electrophoresis. Letter C, those with HbH disease have a loss of 3 loci. Letter D, diagnosis is made by a globin gene analysis. And letter E, HBH disease have increased beta tetramers? Okay. Okay, and the correct answer for question number 5 is letter B.
Alright, so for this part, the only house who got it correct is the House of Gryffindor. Congratulations. You may now see your score in the scoreboard, after which you can leave the platform, Doctor. Thank you.
So we have the following students to answer question number 6. We have Petron Angeli Rose Dominic from the House of Ravenclaw. We have Rajendran Manikumar from the House of Hufflepuff. We have Laput Maria Zania Miguela Gryffindor from the House of Gryffindor, and Sai Manpreet from the House of Slytherin. Okay, Ma'am Janice, kindly verify the students.
They are all verified, Doctora.
Okay, so this is the question number 6. Postpartum hemorrhage definition are true, except letter A, blood loss of more than 500 ml following vaginal delivery. Letter B, blood loss of more than 1,000 ml following cesarean section. Letter C, any amount of blood loss that threatens hemodynamic stability. And letter D, failure of the uterus to contract after delivery. And letter E, uterine atony is not a cause of postpartum hemorrhage. Again, postpartum hemorrhage definition are true of the following except letter A, blood loss of more than 500 ml following vaginal delivery. Letter B, blood loss of more than 1,000 ml following cesarean section. Letter C, any amount of blood loss that threatens hemodynamic stability. Letter D, failure of the uterus to contract after delivery. And letter E, uterine atony is not the cause of postpartum hemorrhage. Kindly answer. And the correct answer is letter E. Okay.
Alright, so for this part, the following houses got the correct answer. House of Gryffindor, the House of Slytherin, and the House of Ravenclaw. Thank you so much, Doctor. So you may now see your score in the scoreboard, and then you may leave the platform. Thank you.
Okay, so we are now in question number 7. The following participants are, from the House of Ravenclaw, we have Basilio John Benedict. From the House of Hufflepuff, we have Sanganagari Somia. From the House of Gryffindor, we have Daos Kinore. And from the House of Slytherin, we have Pupusami Kumarabelan. Question number 7. The following are true of human chimeras. Okay. Letter A, humans with 2 sets of DNA. Letter B, fraternal twins in utero when one twin dies and the surviving twin absorbs its twin DNA. Letter C, it can happen in bone transplantation. Letter C, pregnant woman. Letter D again, pregnant woman may retain some DNA from her baby if some fetal cells happen to migrate outside the uterus, also known as microchimerism. And letter E, all of the above. Again, the following are true of the human chimeras. Okay, letter A, humans with 2 sets of DNA. Letter B, fraternal twins in utero when one twin dies and the surviving twin absorbs its twin DNA. Letter C, it can happen in bone transplantation. Letter D, pregnant women may retain some of the DNA from her baby if some fetal cells happen to migrate outside the uterus, also known as microchimerism. And letter E, all of the above. Kindly answer. And the correct answer for this number is letter E, all of the above.
Okay, so for this number, the following houses got the correct answer. The House of Gryffindor, the House of Slytherin, and the House of Ravenclaw. Congratulations. You can see your scores in the scoreboard, after which you may now leave the platform. Thank you, doctors.
Okay, so we are now in question number 8. We have the following participants. From the House of Ravenclaw, Rubinus Ferdinand. From the House of Hufflepuff, we have Patidar Saloni. From the House of Gryffindor, we have Estrella III Robert Raymond. And from the House of Slytherin, we have Batkiri Sueta. Okay, students, kindly turn on your video. Okay, all right, all participants are ready. Question number 8. Okay, for question number 8, uterine inversion risk factors except letter A, rapid labor, letter B, invasive placentation, letter C, long umbilical cord, letter D, Marfan syndrome, and letter E, Ehlers-Danlos syndrome. Again, uterine inversion risk factors are the following except letter A, rapid labor, B, invasive placentation, C, long umbilical cord, D, Marfan syndrome, letter E, Ehlers-Danlos syndrome. Kindly answer, please. And the correct answer for question number 8 is letter C.
Alright, so for this number, the following houses got the correct answer. Letter C for the House of Ravenclaw and the House of Slytherin. Congratulations. So you may now check the scores of your houses in the scoreboard, and then you may leave the platform. Thank you, Doc.
Thank you, Doc.
So we are now in question number 9. The following are, we have from the House of Ravenclaw, we have Umali Milmar. From the House of Hufflepuff, we have Mayana Zishan Ahmed Khan. From the House of Gryffindor, we have Concepcion Serena Kaira. And from the House of Slytherin, we have Kanagaraj Sriram. Okay? Ma'am Janice, kindly verify the students.
They are all verified, Doctora.
Okay, so in peri-procedural death, not classified, the manner of death is letter A, natural, letter B, accident, letter C, homicide, letter D, suicide, and letter D, undetermined. Okay, in peri-procedural death, not classified, the manner of death is one of the following: letter A, natural, letter B, accident, letter C, homicide, letter D, suicide, and letter E, undetermined. Okay, kindly answer. So the correct answer for question number 9 is letter E, undetermined.
Alright, so for this number, the following houses got the correct answer. The House of Ravenclaw and the House of Slytherin. Congratulations.
Yes, Ravenclaw and Slytherin only got the right answer. Congratulations.
Okay, you may now see your scores in the scoreboard, and then you may leave the platform, doctors. Thank you.
Okay, so we're now down to the last question. Question number 10. We have the following participants. From the House of Ravenclaw, we have De La Torre Gioni. From the House of Hufflepuff, we have Mohammed Rajab Asihabanu. From the House of Gryffindor, we have Legada Jael Hana. And from the House of Slytherin, we have Gautam Priyesh Kumar. Okay, kindly verify, Ma'am Janice.
They are all verified, Doctora.
The question is, in peri-procedural class of death involving inherent risk of invasive procedure or surgery, that what format will use? Okay, letter A, combined format, letter B, split format, Letter C, variable format. Letter D, all of the above. And letter E, none of the above. Again, in peri-procedural cause of death involving the inherent risk of invasive procedure or surgery, what format will be used? Letter A, combined format. Letter B, split format. Letter C, variable format. Letter D, all of the above. And letter E, none of the above. Kindly answer. 15 seconds. And the correct answer is letter A, combined format. Okay.
Okay, so for this number, all of the houses got it correct except for the house of Gryffindor. Okay, so you may now see your score in the scoreboard and then you may leave the platform, doctors. Thank you so much. To discuss the case, let us listen to the department chair, Dr. Serviliano Retualo.
Good morning. I now welcome you to the Prosector's Report, Part 2, the 6th Annual Grand CPC for the September batch, regular and customized. I am Dr. Serviliano Retualo III, Professor, Chair, and Coordinator of the Faculty of Pathology, Junelta Foundation School of Medicine, Perpetual Health, Dalton. Disclosure. This CPC was taken from my personal collection of postmortem cases when I was still working for the United Nations Peacekeeping Operations, the World Bank Health Reconstruction Program, and the Italian Cooperation Program covering the period 2005 to 2014. The patient's personal data and nationalities are, in this case, been altered to protect their true identities, and the case protocol has been improved for educational purposes. Methods. In June 14, 2010, a request was forwarded to me to conduct a postmortem examination on a postpartum female to determine the cause of death and implication on the ongoing maternal health care policies being implemented in this country at that time. Specimens of the patient were sent to international agencies for hemoglobin studies since PCR testing was not yet available as a routine test during those times. External examination. The body was that of a middle-aged Negroid female wrapped in blankets, 148 centimeters height, and weighed 75 kilograms. The IV lines and endotracheal tube was noted to be in situ. Noted is a surgical incision on the anterior abdominal wall extending from the xiphoid junction to the suprapubic area, measuring 27 centimeters by 0.5 centimeters. Bending puncture marks on the antecubital fossa of the right and left arm, which measure 0.2 by 0.1 centimeters. Internal examination. Serous cavities. Pleural cavities. The pleural cavities showed serous sanguineous pleural fluid amounting to 140 ml. The pericardial cavity showed no gross deformity. The peritoneal cavity showed blood clots and serous sanguineous fluid amounting to 100 ml. Internal examination. Head and neck. Dissection of the heads revealed no subglial hematomas. The brain was edematous and with venous congestion and weighed 1,040 grams. Cardiovascular system. The heart was noted to be enlarged and weighed 520 grams. Right ventricular wall was measured at 1 centimeter, left ventricular wall at 2.5 centimeters. The open valvular measurement as follows: tricuspid valve at 8 centimeters, pulmonary valve at 7 centimeters, the mitral valve 5 centimeters, and the aortic valve 3 centimeters. Coronary arteries. The coronary ostium was noted to be patent. The main branch of the left coronary artery was noted to be 45% occluded at the distal end. The right coronary artery was patent, and the left circumflex artery was also noted to be patent. The aorta showed no gross pathology, as fluid as superior as a vena cava. Respiratory system. The airways, the pharynx, the hyoid bone, the larynx, trachea, and bronchi were all unremarkable. Lungs. The right lung was weighed at 760 grams and measured 23 by 13 by 6 centimeters. The left lung weighed 520 grams and measures 19 by 15 by 5.5 centimeters. Cut section showed edematous and reddish frothy secretions with areas of reddish discoloration along the upper and middle lobes. Microsections revealed microtrobi in the blood vessels showing ischemia, necrosis, and fibrin deposition were noted. The diaphragm showed no gross pathology. Alimentary system. Oral cavity showed no gross pathology. The hyoid bone was intact and showed no fracture. Esophagus showed no gross pathology. The stomach was noted to be reddish brown with contents of partially digested food. The intestines showed no gross pathology. The liver is brownish red and weighs 2,000 grams and measures 32 by 16 by 12 centimeters. The gallbladder showed no gross pathology. Biliary tree showed no gross pathology. The pancreas showed no gross pathology. Genitourinary system. Kidneys. The left kidney is grayish brown, smooth surface, and weighs 100 grams. And measures 10 by 6.5 by 1.5. The right kidney was noted to be yellowish brown, smooth, and weighs 140 grams and measures 13 by 8 by 2.5 centimeters. Cut section shows hemorrhages in the cortex and medulla. Microsections of the kidney revealed microthrombi in the glomeruli, which with ischemia and necrosis and fibrin deposition. Ureters and bladder showed no gross pathology. Uterus and ovaries. The uterus is soft and flabby and measures 10 by 8 by 6 and weighs 850 grams. The cervix measures 3 by 1 centimeter. The cervical os is open with stellar shape and a diameter measuring 1.2 centimeters. Ovaries and fallopian tubes show no gross pathology. Coronal bisection of the uterus reveals minimal herniation of the fundal portion of the portion into the uterine cavity. Serosanguineous fluid amounting to 50 ml and blood clots were noted in the uterine cavity, and no placental tissues were noted. The myometrium thickness was measured at 3 centimeters. The endometrial thickness was measured at 5 centimeters. Noted are numerous cysts in the myometrium, the largest measuring 2 by 2 centimeters. Microsections of this cyst reveal irregular nests of glandular endometrial stroma. The endocerval canal measures 2 centimeters. Noted is a sessile ulcerated masses along the endometrial cavity measuring 0.5 by 0.5 centimeters extending to the external cervical os. Microsections reveal hyperplastic, cystic endometrium. No vaginal sidewall lacerations were noted during dissection. The endocrine system, the pituitary, thyroid, and adrenal gland show no gross pathology. In the reticuloendothelial system, the spleen revealed grayish-brown surface. It weighed 500 grams and measured 14 by 10 by 6. Cut sections reveal reddish frothy secretions. Lymph nodes showed no gross pathology. The extremities, No gross pathology was noted. Skeletal system, no fractures were noted. In the laboratory examinations, hemoglobin electrophoresis was done, revealing 35% of hemoglobin bar. Our cause of death. Part 1, the immediate cause of death is postpartum hemorrhage, disseminated intravascular coagulation, subacute incomplete uterine inversion with dysfunctional uterine bleeding. Our antecedent cause is intraoperative complications of exploratory laparotomy, which they were trying to do emergency hysterectomy, and peritherapeutic complications of massive blood transfusion. Our underlying cause is thalassemia, HbH at 35%. Other factors contributing to the death of the patient is adenomyosis, the ulcerated cervical polyps, which are causing the bleeding. We also have ABO chimerism and consanguine relations and homozygosity in the family history of this patient, which revealed some sort of genetic problem from the start. So may I go to the discussion? Our initial discussion will be on postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal mortality, and all women who carry a pregnancy beyond 20 weeks of gestation are at risk for postpartum hemorrhage and its sequelae. Although maternal mortality rates have declined greatly in the developed world, postpartum hemorrhage remains a leading cause of maternal mortality elsewhere, like in this country of limited resources. The definition of postpartum hemorrhage is somewhat arbitrary and problematic. Postpartum hemorrhage is defined as a blood loss of more than 500 ml following vaginal delivery or more than 1000 ml following a cesarean section. A loss of these amounts within 24 hours of delivery is termed as early or primary postpartum hemorrhage, whereas such losses are termed late or secondary postpartum hemorrhage if they occur beyond 24 hours after delivery. A healthy woman has a 30-50% increase in blood volume in a normal singleton pregnancy, and much is more tolerant of blood loss than a woman who has existing anemia, such as our case, probably an underlying cardiac problem condition, and a volume contracted condition secondary to dehydration or preeclampsia. For these reasons, various authors have suggested that postpartum hemorrhage should be diagnosed with any amount of blood loss that threatens hemodynamic stability of the woman. The pathophysiology of DIC is seen as a result of the following simultaneous occurring mechanism. Number 1, tissue factor or mediated thrombin generation. Number 2, dysfunctional physiologic and anticoagulant mechanisms such as depression of antithrombin and thrombin system, which cannot be adequately balanced in this thrombin generation. We also have number 3, impaired fibrin removal due to the depression of fibrinolytic system. This is mainly caused by high circulating levels of phospholipid activator inhibitor type 1. However, in exceptional forms of DIC, fibrinolytic activity may be increased and may contribute to bleeding like what we have in this case. And finally, any inflammatory activation may be caused by the hemolytic generation in disseminated intravascular coagulation. Obstetric and transfusion causes of acute hemorrhagic disseminated intravascular coagulation are as follows: amniotic fluid embolism, ablapsio placenta, acute peripartum hemorrhage like what we have here, preeclampsia, eclampsia, hemolysis, elevated liver enzymes, and low platelet count syndrome, stillbirth, septic abortion, intrauterine infection, acute fatty liver of pregnancy, and hemolytic reactions and transfusion. We probably be seeing some acute peripartum hemorrhage and transfusion in our case that would predispose our patient to DIC. Uterine inversion. Uterine inversion is one of the most serious complications of childbirth. Uterine inversion refers to the collapse of the fundus into the uterine cavity. Excessive umbilical cord traction with fundal attachment of the placenta and fundal pressure is in the setting of a relaxed uterus are the two most common proposed etiologies for uterine inversion. Other possible risk factors for uterine inversion include rapid labor, invasive placentation, manual removal of the placenta, short umbilical cord, use of uterine relaxing agents, uterine overdistension, fetal macrosemia, multiparity, placenta previa, connective tissue disorders such as Marfan syndrome and Ehlers-Danlos syndrome, and a history of uterine inversion in previous pregnancies often occur that carries a high risk of mortality due to hemorrhage and shock. Degrees of uterine inversion as follows: incomplete, such as our case, fundus inverts but does not herniate through the level of the internal os. Complete, the internal lining of the fundus crosses the cervical os with no palpable fundus abdominally. Prolapse, entire uterus prolapsing through the cervix with the fundus passing out of the introitus. Our classification is as follows: acute, this will happen within 24 hours or less after delivery. Subacute, if it happens longer than 24 hours postpartum. And chronic, if it is longer than 1 month postpartum. In our case, it is subacute. So it's incomplete subacute uterversion. The pathophysiology has 3 possible events for acute uterine inversion. Number 1, a portion of the uterine wall prolapses to the dilated cervix or indents forward. Number 2, relaxation of the part of the uterine wall. Number 3, simultaneous downward traction of the fundus leading to uterine inversion. We go now to thalassemia syndromes, which our patient has been diagnosed of, an HBH type. Of the genetic disorders worldwide, thalassemia syndromes are the most common. Normal adult hemoglobin produced after birth with hemoglobin A consists of a heme molecule linked to 2 alpha globin and 2 beta globin chains, with the alpha globin chain production dependent on the 4 genes on chromosome 16, and a beta globin chain production rising to the 2 genes on chromosome 11. Deletions or mutations on one or more of these genes so that the rate of production of alpha and beta chains is reduced results in alpha thalassemia or beta thalassemia respectively. Thalassemia is usually asymptomatic in carriers or presents with anemia of varying degrees in patients whom globin chain production has been severely impaired. Although hemoglobin electrophoresis is not sensitive enough to diagnose alpha thalassemia, it can be useful in quantitating and identifying the different hemoglobin types, as what we have in our case. Hemoglobin BARTs is elevated at birth in patients with alpha thalassemia, and in persons with HBH disease, as our cases, we have 20 to 40% of total hemoglobin, which is supposed to be hemoglobin BART, along with typical findings of adult hemoglobin A, hemoglobin A2, and hemoglobin F. In silent carriers, however, the percentage is only 1 to 2% with low or normal amounts of hemoglobin alpha 2. In persons with alpha thalassemia trait, hemoglobin BART accounts for 5 to 15% of total hemoglobin. Alpha thalassemia results from the deletion of one or both of the alpha globin genes on the same DNA strand, and more than 35 such deletions described. Severe alpha thalassemia cases are represented by alpha-alpha negative to show the absence of both alpha globin genes. This is a common finding in alpha thalassemia carriers in Southeast Asia, in southern China, or the Middle East, who are therefore at risk of having stillbirth with hemoglobin BART hydrops fetalis, which happened to the son of this patient who developed hydrops fetalis after birth. Inbreeding depression. The biological effects of inbreeding depression in humans are largely obscured by socio-economic cultural influence of reproductive behavior. Studies in human population have shown that age at marriage, duration of literacy, contraceptive use, and reproductive compensation are the more major determinants of apparent infertility, and amongst the population with high proportion of consanguineous unions. However, Several small effects on increased mortality, longer birth intervals, and reduced overall productivity have been noted in certain isolated populations. It is very common in this population to have inbreeding because of the so-called practices of the different tribes that we have. Now we go to a more controversial issue of this case, our ABO discrepancy, in which there was supposed to be a changing blood type before the actual transfusion. We probably have to turn this a problem to consider chimera. But we go back to some sort of history. Iliad described the chimera, which we see as most of the structures that we see in the older times, as a thing of immortal snake, not human, blind-fronted, snake behind, a goat in the middle, and starting out of breath of a terrible flame of fire, probably a dragon. This mythical creature has a lion's head, a goat's middle, a tail of a serpent, and the sighting of the chimera was considered to be a very bad omen for disaster. Thankfully, not so much in the blood bank. Though ABO discrepancies can be a challenge, even though most chimeras can be easily resolved with a few additional steps and with the patient's history. So these are the ABO groupings discrepancies that we see in the lab. These are broken down into either a subgroup A or B, a genetic chimera, it could be probably with our case, an artificial chimera, also with our case because of the massive blood transfusion, polyagglutination, substances in the plasma or serum, a positive direct anti-glooms test, and finally reagents. We, as students before in medical technology and medicine, and later on become doctors and residents, whenever we have changing blood types, we have only several things to blame. Most likely it could be the reagent, it could be the procedure, and finally it could be the person. And most of the time the lab just backs down and say, oh, it's just the reagent or the person who made a small mistake or typo error or something like that. But now today we are able to be able to designate and be able to find out whether or not we are dealing with a true chimera or maybe an artificial chimera. Chimeras are two cell populations. A natural chimera in utero is an exchange of erythropoietic tissue between two non-identical twins. The strength of the reaction with ABO typing depends on the percentage of A or B cells in the blood. This is for natural chimera. A temporary chimera, which follows a transfusion with ABO compatible but not identical blood. In our case, it was supposed to be an A that became a B and became an O. So we had the patient was then transfused with O type blood. Twins have chimeric blood group that lack A and B antibodies, and chimera with 98% O cells and 2% B cells are grouped as O, and serum may only contain an anti-A. To review, ABO discrepancy occurs when unexpected reactions occur in the forward and reverse group typing, or the forward typing does not match the reverse typing. Some weak subgroups of A, notably A3, are known for giving mixed field reactions. Weak activity with anti-A, anti-B, or anti-D can also result in mixed field reactions. This is usually we find in our leukemia patients. In these examples, the mixed field reactions are due to weakened expression of the corresponding antigens. Like the mythical beast, a chimera in biology describes an organism that has two cells from two or more zygotes. When chimerism exhibits only in the blood, the phenomenon can be termed as an artificial chimerism, as described above, as the spermic chimerism or as twin chimerism. The spermic chimerism occurs in other animal species, but it is a rarity in human beings. It occurs when two eggs are fertilized by two sperm, and these products are fused into one body. In this case, the chimerism is not limited to blood, but also may result in hermaphroditism and two different sets of skin colors or even eye colors. Maybe you have seen this in some of the animals that you have taken care of, such as cats. They're most common. I see cats with two colored eyes. These are chimeras. Chimerism is the presence of two cell population in a single individual. There are scenarios where ABO discrepancies causing mixed field reaction indicate apparent chimera, such as in our case. A group A positive patient who receives several units of O negative blood will have mixed field reaction due to the presence of two blood types in the peripheral blood. This would be a temporary situation. A patient who receives a bone marrow or stem cell transplant from a non-group identical donor will also have two populations of red blood cells until the new type is established. We refer to this as artificial chimera cases, as the second blood type is not naturally occurring, but present due to the introduction of different blood types by transfusion or transplantation. Twin chimerism occur when in utero, one twin transfuses blood cells, including stem cells, to the other. Since the fetal immune system is immature, the host does not see this transfused blood as foreign antigens. The stem cells can proliferate, and this results in the production of cells from both the donor and the host for the rest of the individual's life. Two non-compatible blood groups can coexist in one individual. That's chimerism. This phenomenon is usually discovered by coincidence during routine type and screen, and the patient could have a mixed field or weak reactions on ABO typing, or can have missing reactions in the back type, all with no history of transfusion, transplantation, or no disorder that could explain these findings. What would a tech do? An important step in this resolving ABO is to review the patient history. This happened to me 3 years ago when the staff of the hospital called me up in the middle of the night for several times that they could not explain a possible change in blood type, and they were all blaming the blood donor, the blood type, the reagent, the person who did it. And I told them that probably have to review the history, and the history did show that this person had a twin, and probably I said maybe this is a chimera. In 1953, a human chimera was reported in the British Medical Journal. A woman was found to have blood containing two different blood types. Apparently, this resulted from her twin brother cells living in her body. More recently, in 2014, a case was described in Blood Transfusion describes a 70-year-old female who was found to have mixed field reactions with ABO and RHD typing during routine testing before surgery. She had no history of transfusion or transplantation and a history of 7 pregnancies. Repeat testing by other methods with different reagents gave the same results. On further questioning, the patient affirmed that she had born a twin, and her twin brother had died as an infant. Since chimerism was suspected, a molecular typing and flow cytometry was performed and revealed such. The presence of male DNA was found by PCR testing, and flow cytometry confirmed that 2 distinct populations of red blood cells are found. So these are the 2 examinations done in the laboratories at present to determine whether or not we are dealing with a chimera. PCR testing and flow cytometry for the red blood cells. How common is blood chimerism? 1996 study showed that such blood group chimerism is not rare. Though we do not often encounter in the blood bank, their study of 600 twins and 24 triplets show that this occurs more openly in original thought with higher incidence in triplets than in twins. Because it does not cause any symptoms or medical issues, many such chimeras go undetected. In addition, the study found that many of these chimeras have very minor secondation, making them undetectable in serological testing. In the blood bank, we generally test for ABO/Rh and do not test for other antigens in routine testing. This study used 849 marker antigens. Transfusion, stem cell transplant, kidney transplantation, intravenous and artificial insemination can all lead to temporary and sometimes permanent chimeras, even pregnancy. This represents a challenge in blood bank laboratory and interpreting results for patient management. A question of chimera presence can be usually solved by putting our detective hats and investigating patient's history. Further testing can be done with flow cytometry and molecular methods indeed, if needed. Modern medicine may give given us more blood bank challenges, but modern technology has equipped us with newer methods to solve them. We go to the final here, most controversial. the cause of death statement for peri-procedural deaths. I think all of the four houses, only one placed a peri-procedural death in their cause of death statement. Okay, writing causes for death for peri-procedural deaths. Peri-procedural deaths refers to death that is known or suspected to have resulted in whole or in part from a diagnostic, therapeutic, or anesthetic procedure. The procedure may be as simple as administration or ingestion of a drug. It also referred as misadventure, a iatrogenic or error accident in medical care. Such words of misadventure and iatrogenic may connote negligence. Many procedural deaths, however, do not involve negligence, mistake, or culpability. It is recognized that the approach to certifying such death varies, and the certifier must have the liberty to write the cause of death statement which best meets their need in a particular case. These are the major cause or major international classification of death categories of peri-procedural deaths: accidental poisoning or exposure to noxious substances, drugs, medicaments, biological substances causing adverse effects in therapeutic use, misadventures to patient during surgical and medical care, medical devices associated with adverse incidents in diagnostic and therapeutic use, finally, surgical and other medical procedures as the cause of abnormal reaction of the patient or later complication without mentioning the misadventure at the time of procedure. So, the categories of peri-procedural death may be classified as peri-diagnostic, related to diagnostic agent, procedure, or device; peri-anesthetic, related to anesthetic agent, procedure, or device; peri-therapeutic, related to therapeutic agent, procedure, or device; peri-operative, related to any surgical procedure or device that may be further subcategorized as intraoperative and postoperative. The term peri-procedural is a generic term that may be used to include any of the categories as defined above. The dilemma for writing the cause of death for peri-procedural deaths are: which peri-procedural event constitutes an injury? So the question to be asked: how, where to report injury in the cause of death statement? Usually it's in the antecedent cause of death. How to relate an injury in relation to existing disease processes. How to designate the manner of death. How to completely and accurately certify death without inciting litigation or unduly raising issues of culpability in peri-procedural incidents which presents itself as an injury. Okay, this is the approach for writing our cause of death statement for peri-procedural deaths. The structure or format of the cause statement will be based on your answer to this question: would have death been an imminent in the procedure's absence? Would have the patient died without the procedure? Those answers will give you some sort of guide in how to put everything in your death certification. Now, these are now the medical legal considerations for putting down such peri-procedural deaths. A death certificate is primarily a statistical document we always use, because in our country we do not have too much data on any peri-procedural failures, because it is not placed in your death certificate. That is why we are now blinded into how good our system is when it comes to therapeutic, peri-anesthetic, and even your procedures for surgery. We do not know, we do not have the data for that. That is why the Department of Health would like to have this included in our death certification, but it has some sort of medical legal consideration that need to be addressed. It may constitute an important source of information for family members and other people or agencies who may impart too much or inappropriate significance to the death certificate, especially if they're not aware of the general purpose, limitations, and opinion-based nature. In other countries such as Singapore, the medical certification of death, in which constitute a peri-procedural problem, is not immediately given to the legal authorities or the police for investigation. It is the medical council that determines whether or not such nature done for this peri-procedural deaths constitute a negligence. Only then it is given to the legal authorities. Other than which, it is never given, and it is always classified either an accident, or natural death. A major issue to those who certify periprocedural death is the concern whether or not the cause of death, wording, or manner of death classification would foster litigation, as I just said. Unnecessarily implicate a treating physician or other person or agency, and alienate professional colleagues, unnecessary alarm family members and survivors. The Singapore system has been able to solve it by placing all of this under a magistrate who decides whether or not it could be used as legal or not. So it is the medical council who first determines, and then later on, if there is some sort of negligence, it is given to the legal authorities or the justice system. A problem may result in the cause of death statement if it's oversimplified or the certifier omits complications because of some people may receive an attempt to conceal facts or cover up a problem. That has always happened because sometimes a patient will die intraoperatively and they will blame anything in there from medications, therapeutics, even anesthesia. But I've always tried to be there and always tell them that such things are all out of an accident, has never been intended, and there's no negligence as long as the procedure for any surgical procedure has been followed. An objective approach is based on documented reasonable probable facts to minimize such problems through stating the truth truth to the best of one's knowledge. Okay, these are philosophical issues and school of thoughts. A common school of thought is that predictable, anticipated, or expected periprocedural complications are extensions of underlying disease process, and that the underlying cause of death may therefore be attributed to the disease and to the complication of the disease while ascribing it as a natural cause of death. In most cases, it is. The cause of the manner of death in our case that we have just described is a natural cause of death because death was definitely imminent with so many complications that could not be solved all at the same time. The options above allow the school of thought to be followed in practice, but also allowed other schools of thought to be practiced as deemed appropriate by the certifier of death. Our manner of death: high-risk surgical patients who die while undergoing or after high-risk procedures may be classified as natural if it appears that the normal and unavoidable stress of surgery underlying disease resulted in death, which was what was caused in our patient. Our resource person, Dr. Benny Chanko, will now probably discuss more issues on this that is concerning a present situation here in our country. Okay, with that, I would like to leave you with the saying, pathology is the foundation of medical science and practice. Without pathology, the practice of medicine would be reduced to myth and folklore. So I thank you today and to all of you.
At this point, we would like to thank each and everyone. To the President of the University, Mr. Anthony Tamayo, School Director, Dr. De Guzman, to our Dean, Dr. Emelita Gatmaitan, Dr. Charlene Ramos, and Dr. Wendy Nicanor, the school coordinators for the customized and local students. To our Board of Judges, the faculty members, our guest mentors, and the students. This has been a successful and triumphant activity of the Department of Pathology. Congratulations to all of the best efforts made, and most especially to our winner. This has been your host, Dr. Jennifer Mateo and Dr. Iftisar Haron. Before we end this program, a closing remarks will be given by Dr. Emelita Gatmaitan, the Dean of the Ginelta Foundation School of Medicine, to be followed by the awarding of winners by the Dr. Serviliana Ritualo, the Chair of the Department of Pathology.
Once again, we have come to a close of the virtual Clinical Pathological Conference, and I cannot help but express my sincerest gratitude to the Department of Pathology, headed by Dr. Ritualo and the rest of the faculty staff, for their untiring efforts to make this virtual activity a success. Thank you very much. To the students, congratulations for your wonderful enthusiasm at presenting the case with much vivid audio visuals and considering the possible conditions and finally arriving at your perceived diagnosis. To the judges who have devoted their precious time to to witness this event. Thank you so much. May we all stay safe and stay alive. Good day, everyone.
Now we go to the this part of the declaration of the second part CPC winner and the 6th annual Grand Champion for the 2021 annual Grand CPC. Before we do that, we would like to make a review on who were the champions in the last years. So we have this is the 6th year of our Grand CPC, and you will notice from the chart that from 2016, 2017, and 2019, it was Slytherin who became the Grand Champion, Gryffindor in 2018, and last year it was Hufflepuff who won the overall Grand Champion. Now let's go to the scores. How they scored. Each of the houses were judged based on their graphics, media content, their presentation skills, the mastery of the case, the ability to answer to be judged by one judge, given a score, and then your MCQ question composed of your 10 participants from the house, which are randomly picked. There are the average of each of the graphics, presentation skills, and mastery of the case. And we go now to the summary. Okay, this is the final scores. For graphics and video content, it is Gryffindor who mastered there by getting 18.5. And for presentation skills, it's a tie between Gryffindor and Ravenclaw at 18.25. For mastery of the case, that category was won over by Ravenclaw at 19. And for the ability to answer, Hufflepuff and Slytherin got 18. For MCQ questions, it was Slytherin who was able to get 14 points. Now for the total, for Hufflepuff, they got 73.75. For Ravenclaw, it's 83.5. And for Slytherin, it's 81. And Gryffindor, it is 77. So, we have our second part champions. It's Ravenclaw, the winner of the second part of the 6th annual Grand CPC with a score of 83.5. Mentored by Dr. Dave Olveda, the Assistant Chair of the Department of Pathology, and Dr. Rodolfo M. Pascual, our Consultant Mentor from the Department of Obstetrics and Gynecology. This second part score is now added to the first CPC. So for the first CPC, Hufflepuff got 78.5 and 73.75 for the second CPC for an average of 76.13. Ravenclaw got 83.25 in the first CPC and got 83.5 in the second CPC for an average of 83.38. Now for Slytherin, it is 81.25 for the first CPC and 81 for the second CPC for a total of 81.313 for the entire CPC. And then for Gryffindor, they got 83 in the first CPC and they got 77 in the second CPC for an average of 80. So there you have it. We have our now champions. We would like to congratulate Ravenclaw to becoming the champions of the 6th annual Grand CPC online for 2021. And they have an average of a score of 83.38. And they are mentored, I would like to repeat again, by Dr. Dave Olveda, our Assistant Chair of the Department of Pathology, and Dr. Rodolfo M. Pascual, our mentor, consultant from the Department of Obstetrics and Gynecology. So these are the presenters, the champions. For the first CPC, it is Alonso John Christian, Serna Kim Martina, De La Torre Joni, Pension Angeli Rose Dominic, Ramos Giovanni, and they were judged by Dr. Bernadette Espiritu. And for the second CPC, the presenters are Bangalan Kylie, Bejob Josel Andy, Boot Jillian Bettina, Jacob Mariam Erica, Naring Hanon Jessa Andrea, and they were judged by Dr. Limio Sago. So here we have it. We have after 6 years, we now finally added Ravenclaw as the champion. Our all champion Grand CPC for online CPC 2021, Ravenclaw. Congratulations to the House of Ravenclaw. Thank you very much.
Il m'a dit t'es où, je te rejoins en tel. Moi je m'en bats les reins, j'ai besoin d'un vrai job. Il a vu mes copines, je crois qu'il a flashé. Je suis pas ton plan bête, à ma télé fessée. Je réponds à tes appels, tu crois que je vais la fesser. Moi je m'en bats
We have come to the conclusion of the 6th annual online Grand CPC for 2021. Again, I would like to give my congratulations to the winner, Ravenclaw. And it has already been 487 days in the start of this pandemic. And I hope to see you in the next CPC, and I bid everyone to take care and stay safe. And this healing charm, Anapio Infinite Encantum.